if there is a new drug available, we are very, very open to, using it, because we don't think that we are, it is against us. But somehow when it comes to the endometrial receptivity, we always tend to pit it against our experience, which is not required. And in that process, we tend to take it more personally, and then I guess we lose the way. Because world over, when I met Carlos, he said we have analyzed more than 30,000 patients in 5 different continents. Now, when you have such a humongous data, then obviously we cannot just brush it aside saying that no, it doesn't work. And I personally was humbled when I saw the endometrial receptivity in a young girl at 96 hours. That's something, it was not known to me that blastocysts can get implanted after just 4 days of progesterone. I never knew this. So this was completely against this thing. And then I started finding out a little bit, and I think that ERA definitely has the potential. Cost is a main constraint, sir, I feel. If the cost comes down, people will be open to, using.
Absolutely. Because in Indian population, what happens, our patient, if we tell them to spend 1 lakh rupees extra for the test, they will spend immediately without any hesitation. At least in Mumbai, I know. But our mentality remains same everywhere. The moment we spend something extra, then we want assurance about the result.
Yes.
And unfortunately, that cannot be guaranteed. That cannot be guaranteed.
Yes. So I think we should consider ERA as our friends, I feel, but most of us, just unnecessarily put it against each other, and that most of the problem is that, like, very senior specialists like you are very open for these newer things. But most of the seniors, they openly castigate ERA on an auditorium, in big conferences, and then juniors really don't know what to do.
Because what happens, most of the IVF specialists, they are, there are different categories. One category, they exactly follow what they have been taught by their mentor. And most of the time, mentors are old school people. So they are not open, and they follow exactly same thing, what they have been doing since many years. So one class is like that. Another class, they are too busy in their obstetrics. So they do not have time only to read and know the evidence, what exactly right and what exactly wrong. So they rely on somebody who is, they keep asking some or other person. And unfortunately, suppose they ask to a person who are not well versed with the recent literature, then they are carried away by their opinion. And because they do not have time to find out the evidence for them. So the second category. And third category are like us, who are always open to accept new ideas and who are really striving to achieve higher and higher success rate, and who are doing the IVF passionately. So even for us, for me, if you ask me, number is not a very great attraction for me, because it's in the metro city.
It means a lot, sir, to me, person like me, to hear from you when you say this. It really means a lot.
But the great pleasure when we deliver the success, and we do the thing, same thing. Probably everybody is doing the same thing, but knowing it from in depth and doing, that is another pleasure, another level of pleasure. Rather than just following what has been taught to you.
Yes. I feel, sir, I somehow look at failed IVF cycle and, recurrent miscarriage in the similar lens that previously, somebody doesn't abort for 3 times, nobody will, just investigate her. Now even one abortion is taken very seriously. Similarly, we cannot accept one failed IVF cycle, just like old times. Now we have to be that much, aware about it, that if cycle has failed, there has to be certain reason which we have to find out.
Dr. Chinmay, it seems that initially your voice was much clear, and now your voice is little, as if it is coming from distance. Now it is fine. Yes, it is coming from the. You need to adjust your microphone, I think so.
Yeah, I have just now adjusted the microphone, and good that while we are talking, we sort out this small things. Yeah. Now Sachin Dalal is calling. I'll just speak to him. Yes, Sachin bhai. हाँ, अभी आएगा आपको. Koradia sir has already pointed that out. and we have corrected. Now you will hear it. Can you please just see and give me thumbs up on WhatsApp if you hear? Yeah.
Yes, absolutely fine. Now it's fine.
Now, okay, sir. I think, sir, now we are
Let us.
ready. Probably.
Yes, 105 participants are there. So,
Okay, hello. 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 Sachin bhai.
Chinmay.
Yes. Okay.
Dr. Jay is requesting to hold on for 5 minutes to 7 minutes more because
Okay.
he has some for 50-70 participants are expected to join.
Okay. Great.
So he is requested to hold on for 5 minutes more.
Yeah.
So
Yeah.
that
We
is
will.
fine. Absolutely. I think we just continue some of the discussion. So
Sure.
basically, how I look at the endometrial and embryo interaction,
Yes,
I
sir.
compare it with the suppose a builder has constructed a flat
Okay.
and somehow from somewhere he came to know that okay, you are interested to buy a flat. So he does primary prepares the infrastructure, constructing walls and basic lights and everything, basic tiling and everything. And then the moment he come to know that okay, you want a absolutely perfect, ready to live flat, so he starts doing interior work. So
Okay.
he does to his best level, which should be liked by everybody. But he doesn't know your taste, how
Yeah.
selective you are, how
Yes.
choosy you are. So once that interior work is over, uh, he invites you to see the flat.
Yes.
You are
Yes.
going inside the flat,
Yes.
and you try to understand what is right and what can work and what more you need. So you
Mm-hmm.
start discussing with the person who has done the interior work, and you say that okay, I'm overweight, this chair is not ideal for me, this is
Yes.
not, I want this type, I want this to be done in this way. Now if
Mm-hmm.
it is rectifiable, then everything you say okay, and you enter the home and you start living there. But
Yes, sir.
suppose
Mm.
you find out that a lot of things which are absolutely not suitable to live in,
Okay.
so you reject that proposal. Okay, even though you have done interior, I do not want to live, I cannot live in this flat. Or vice versa, the person who has done the interior, he is finding you too choosy for everything. He will reject you. No, I do not want to give this flat to this fellow. He's too choosy and he is breaking my head. So
Yes.
he also have a right to reject. The
Yes.
story, uh, the you being you were expecting you should uh, he will call you, the builder will call you in next 5 days only, once you knew that the interior work has been started, and
Yes.
and the builder has called you after 7 days or has called you little earlier, then also you do not like, because
Ye-
it is work, it's not as per your requirement. So this is
Yes.
exactly a story,
Yes.
the embryo and endometrium. The
Yes.
estrogen is a builder who prepares the basic infrastructure of the home to be provided to the embryo, and the interior work is done by the progesterone, either secreted internally or externally provided. And the moment the embryo enter inside the home to decide
Yes.
whether you want to stay or you do not want to stay, then comes the selectivity versus rejection. So
Mm-hmm.
you also have power to select and reject, and opposite also have power to select and reject. So
Reject.
when you negotiate into a dialogue, and try to adjust each other. If you
Yes.
are able to adjust and he has called you in time and you enter in time, then everything falls smoothly and you start living, and that's how pregnancy advances.
Beautifully said, sir.
This is how I look at the embryo endometrial dialogue and synchronization. So over to you, Dr. Chinmay.
Yeah.
It's a very important subject, and really I'm looking forward to a lot of inputs from you.
Yes,
Uh,
sir.
Basic thing I have understood about the ERA test and endometrial receptivity, and this is a subject which is not touched upon by many. And if you go to the literature, most of the studies have a very small sample size, maybe 20%, maybe 30%, maybe 40%. So ultimately, those studies, there are certain studies which are against the ERA test, and those studies, some studies which are for ERA test. But ultimately, that because of the smaller sample size, the conclusion remains always a questionable. So as I talk to you in the morning, you
Yes.
have done approximately more than 200 cases, and you have observational, and probably what type of conclusions you have, I do not know. But
Yes,
it
sir.
will be absolutely a fantastic and brilliant idea to know from you, who I believe is an authentic person, to speak on ERA. So, and this is absolutely a selfless platform, so that
Yes.
we will, whatever we are going to provide is absolutely a selfless promotion of the knowledge. It's not a promotion of any test or anything. If it
Yes.
is somebody from Nova or IVI, it is spoken, then probably people will take with a pinch of salt. But I believe you are not connected anyway with them, any of
No,
them.
absolutely not. I have
So,
zero
so
financial
that's
disclosure. Nothing.
yeah, so that's the reason why I was very much excited to invite you
Yes.
for this talk. So over to you, Dr. Chinmay. First,
Yes.
introduce yourself, and then you start your presentation.
Okay. So, hello everyone. My name is Dr. Chinmay Patki. I am practicing in Mumbai. I'm a medical director at Akruti IVF Center. First of all, I would like to take this opportunity to thank you, Koradia sir, for giving me this honor, giving me this opportunity to share whatever little I know about endometrial receptivity and ERA test. I also welcome all of you who have been, patient enough, in this afternoon, Sunday afternoon, and who really are interested in this topic. So let us begin the journey of endometrial receptivity and ERA test. Now, this small organ is perhaps the most mysterious organ in our medical science. This is the only organ which has the ability to give life. Whoever we are, whatever we are born in this cavity. And this cavity holds myriads of secrets. It's like a Pandora's box, and we are just scratching the surface. Here, poetically, the surface means endometrium. And this surface, while we are scratching, we'll come to know slowly about many things. One of them is endometrial receptivity. Now, endometrial receptivity is something which is known since time immemorial. People know when to have intercourse, what is the maximum chance, when to have intercourse so that, there is a good chance of conception and all that. But now is the time when we have to look at the process itself. So what is endometrial receptivity? Endometrial receptivity is a self-limited period during which endometrium transiently transforms to acquire the ability to receive blastocyst and support implantation. Now look at this, just 6 lines, but they are so powerful. It's a self-limited period, first of all. It's a self-limited period. Secondly, the endometrium transiently transforms. And third, and most important, it also supports implantation. Now, what we have to understand here is endometrium consists of multiple layers. Here, there is a functional layer and there are basal layers. The functional layer is responsible for proliferation, secretion, tissue degeneration, and etc. While the regenerative capacity of the organ lies in the basal layer. The human endometrium, I feel it's a dynamic organ. It has capacity to undergo physiological changes in response to ovarian steroid hormones. It can undergo various changes during various different menstrual phases like proliferative and secretory. Now, here, what we have to understand is during the menstrual cycle in humans, the endometrium is basically non-adhesive to embryos most of the time. And it only becomes receptive during a specially and temporally restricted period when the endometrium acquires a functional and a transient status that allows blastocyst implantation. It is very important to understand that the same endometrium, which was not taking embryos before and which will not take the embryo after that window, will have something different during which the endometrium acquires the receptivity to take that embryo. Now, and this itself is called as the endometrial receptivity. This transient period is called as window of implantation. This window of implantation has been postulated to remain open for 5 days after endogenous or exogenous progesterone action. And it then closes 2 days later. Now, a receptive endometrium and a functionally normal blastocyst. Now, please read all lines very carefully. There is a reason I have written these many lines, because I want you to look at each single word. A receptive endometrium and a functionally normal blastocyst, as well as an exquisitely coordinated cross communication between them, are required for implantation. The process by which the embryo attaches and invades the underlying maternal endometrial tissue. Now here, what we understand is during window of implantation, the endometrium acquires a receptive phenotype, which involves both morphological and molecular changes. That means endometrium, just like a magician, it certainly has the capability to wear different hats, and during that window of implantation, it acquires certain receptive phenotypes. Now, what is this embryo and endometrial dialogue? We often talk about endometrium embryo crosstalk. Unless until we understand this concept, there is no point in discussing ERA test. The embryo endometrial dialogue, where the implantation process represents the first major physiological maternal and embryo interaction. It's like mother meeting the child, to-be child first time. It requires synchronized bidirectional communication, followed by adhesion and subsequent invasion of the decidualized uterine stroma. The window of implantation appears to play a critical role in establishing this bidirectional communication. Now I want you to look at this word, bidirectional communication, where both endometrium and embryo both are responsible. Yet, when the cycle fails, we keep on talking about either embryo or endometrium. We very rarely talk about both the factors. Now, human pre-implantation embryos are programmed to produce a lot of proteins and receptors, which act as autocrine and paracrine factors, which can actually elicit changes in embryo developmental phenotype, which can also respond to factors of maternal origin by regulating the proliferation, adhesions, and differentiation. Now, I'll just explain this line. A human pre-implantation embryo has the ability to produce certain factors with which it can exert the changes in itself, as well as it has the ability to exert the changes in endometrium as well. This is the reason why we say that a good embryo knows how to implant itself. Similarly, at the same time, the receptive endometrium is aware of the embryo. Now, please understand this word aware. It's a very powerful word. The receptive endometrium is aware of the embryo, modulating the local immune responses to the embryo-specific factors. Now here, both endometrium and embryos working from their ends to make sure that implantation happens. These signaling pathways are called as the regulatory circuits. So why do we need endometrial receptivity analysis then? Well, answer is pretty simple. As I've written in front of you, we still don't know everything about implantation. And no woman walks into clinic saying that doctor, this is my implantation window. I think job would have been pretty easy if somebody just comes with implantation window in hours, but that's not a fact. And yet, every single woman who bears the pain of repeated IVF failure gets stigmatized for life, thinking it is endometrial dysfunction. Often, I've heard patients say, doctor has told that my endometrium does not take embryo. My uterus does not take embryo. Just imagine how painful these words are. If somebody tells us that we cannot see, even though we have fully functional eyesight, just because we have certain glasses and doctor, perhaps optometrist, doesn't know our glasses number, and then he just judges us as blind, it is the same situation wherein a woman for no fault of hers gets stigmatized for life, thinking that it is her endometrial dysfunction. While fact is, it is not an endometrial dysfunction, but it is an endometrial desynchronization. Now, there is a difference between endometrial dysfunction and endometrial desynchronization. Endometrial dysfunction is something where we are saying that endometrium has no ability to function, while endometrial desynchronization actually puts the onus on us as physicians, as fertility specialists, to make sure that we are able to synchronize this endometrium better. So whatever tool we can lay our hands upon to understand this mystery of implantation better, I feel we should grasp them, knowing fully well that even they won't help us reach the summit. The journey which we are going to understanding the implantation, one thing we will all understand very clearly, that we will still be scratching the surface even after 50 years. But we certainly can act and take a step towards understanding it. Even if we can reduce the repeated failures by a certain percentage, I would still say that we are going in a correct direction. Now, whenever we talk about endometrial receptivity, whenever we talk about endometrium, the work has begun in year 1956. R.W. Noyes, he was the first one who dated the endometrium, and we all have read in our books about dating of the endometrium, various dating parameters and proliferative and secretory endometrium patterns. This is the paper which actually began the journey of looking into how endometrium changes itself, how the phenotype change, how the structure change, how even the molecular biology changes. And in this journey, in this 21st century, we have endometrial receptivity diagnosis. There are various armamentariums we have. One of them is transcriptomics, one of them is proteomics, then secretomics and lipidomics. What I can tell you is currently transcriptomics is seen, it has developed to an extent where everybody is talking about ERA and other things. But mind you, even proteomics, secretomics and lipidomics are definitely moving ahead at a rapid pace. And we will certainly be benefited if all these 4 or 5, omics, if they can develop themselves to such an extent that before putting an embryo, we will actually come to know whether the endometrium is receptive or not. Mind you, as we speak, even currently, the studies are being going on by just obtaining an endometrial sample 24 hours before embryo transfer. Please understand, in ongoing cycle, just 24 hours before we transfer the embryos, if we can take an endometrial fluid and if we can analyze it, there are certain factors based upon which we can actually pronounce whether the cycle is going to be successful or not. And when I say that, I mean to say that we are going to transfer a euploid perfectly normal blastocyst. Now, whenever I talk about endometrial receptivity, please understand that it is taken for granted in this discussion that we are going to transfer preferably blastocyst only, and we are going to transfer a euploid embryos. Now, when I say euploid embryo, PGS is something obviously which comes onto the table for discussion. And since we have to stick to the endometrial receptivity diagnosis, I would like all of us to presume that in this discussion, we are talking about healthy euploid blastocyst. So what is transcriptomics? Now, transcriptomics, it reflects the genes that are being actively expressed at any given time in a specific cell population or tissue. Therefore, it gives the holistic perspective that using single endometrial biomarker is unable to. Imagine you have the entire endometrial transcriptome signature available. wherein you know exactly at that point of time what all genetic signatures are changing. Despite the differences in the studies which compared the gene expression between different stages of endometrium, they all found specific transcriptomic signatures which are commonly visualized with the heat maps. Please understand that even though different studies had their different findings, they all came to one conclusion that yes, there are specific transcriptomic signatures. From all of these endometrial profiles, the most interesting are those of the receptive and mid-secretory phases, because the embryo implantation is only possible during this stage. And we have to concentrate on these transcriptomic signatures which happen during this receptive and mid-secretory phase. Now, these stages are regulated by increasing progesterone levels, and they are characterized by a transcriptional awakening process. Now, please understand this word very clearly. During the implantation process, there is something called as a transcriptomic gene awakening, wherein as if a beast is sleeping, and the moment it realizes it is entering into a window of implantation, it just awakens, and it just leads to a cascade of serial genetic alterations which actually make that non-receptive endometrium changing into a receptive endometrium, accepting that embryo and actually making a life out of it. Now, if we can understand this process seriously, and if we are humble enough in front of nature to understand how complex it is, perhaps that is the beginning in understanding that yes, endometrial receptivity is something which we must be open to learn new things about. Now, here we have to understand what exactly happens in this transcriptomic gene awakening. In front of you, there is a slide which shows multiple phases of endometrium. There are proliferative phases, and then there is window of implantation. I will be talking in detail about pre-receptive, receptive, and post-receptive endometrium. But at the moment, you just concentrate upon the various red, blue lines. These are the heat signatures. These are the signatures which are immense during the receptive phase as compared to non-receptive phase. Now, at a molecular level, what happens is this pre-receptive or early secretory phase is characterized by increased metabolic activity in preparation for the implantation. Please understand this. When I said the beast awakens, that beast now requires food to eat. And that is characterized by increased metabolic activity in preparation for the implantation. This leads to a predominance of products related to the cell metabolism, transport, migration, and then there is also inhibition of mitosis. This receptive phase, which witnesses a transcriptional awakening or upregulation of most gene expression, is what we are interested about. Now here, apart from high level of metabolic and secretory activity, there is also upregulation of genes involved in activation of immune response. During the late secretory phase, the window of implantation closes. And in this phase, genes related to the immune response, both cellular and humoral, they are regulated. Now here, I want you to just simply understand transcriptomic signature like this. I've used this word 2 times before. I'm saying again, just imagine a beast is awakened. Now you don't know from where that beast has come, and you are interested in finding it out. How do you find, that beast for the journey? Just find out the food he's getting from. And we are just doing that. In transcriptomic analysis, what we are doing is we are trying to analyze how exactly the energy metabolism changes during the implantation process, during the window of implantation. Now it is clear that energy metabolism peaks during window of implantation as compared to previous or after. And certainly this metabolism which changes is what is called as a transcriptomic signature. Now, this transcriptomic signature of endometrial receptivity is characterized by expression of 238 genes unique to the window of implantation. Now, please understand, this 238 genes is something which mankind has found out till now. Even in last century, people have now started talking about 270, 280, 300 genes and so on and so forth. I feel this quest will keep on going on. This has led to the endometrial receptivity analysis. ERA is now performed using NGS. Now, when I say ERA, for the benefit, please understand, I'm using endometrial receptivity analysis short form. So ERA is now performed using NGS coupled with a lot of predictors and algorithms, and it actually gives us a personalized window of implantation. And in this ERA, what we are actually doing is we are actually trying to find out from where the energy signatures come from. To perform ERA, a messenger RNA is extracted from an endometrial biopsy, and then it is analyzed by NGS. And it gives us understanding about how the transcriptomic signature changes during implantation, window of implantation. Here it's a beautiful paper in front of you where they've shown that ATP mediates the interaction between a human blastocyst and endometrium. Please understand this. In this, they've clearly shown that ATP plays an important role in human blastocyst and endometrial dialogue. Now, this ATP, which is required for the energy generation, which in turn is required for the gene upregulation, we are behind that analysis. And that is called as a transcriptomic analysis. This led to a genomic diagnostic tool for human endometrial receptivity. Now, please understand, every word I am speaking about endometrial receptivity, right now it is under immense analysis. Every single aspect of endometrial receptivity is having multiple papers every year being presented. Obviously, quoting all those papers is impossible. But to keep a flow of, to keep a smooth flow of our discussion, I'm using a selected paper to first make you understand about what exactly is what we mean by transcriptomic analysis and what exactly is ERA. When we talk about ERA, first we should know what exactly is ERA, and that is what we are talking about. Now, in front of you, this is a paper which shows the genomic diagnostic tool for human endometrial receptivity analysis. This was published way back in 2011, and this led to a commercialization of endometrial receptivity analysis. What we have spoken about, the energy metabolism, this paper exactly showed those things, wherein when they did NGS with ERA test, they showed that yes, definitely there is a energetic relevance in acquisition of endometrial receptivity phenotype. They could show that the energy which is required for this process is obtained from mitochondria, and this mitochondrial changes, which in turn reflects into genetic upregulation, it goes back, the trail goes back to those 238 gene upregulation. And that is what exactly ERA tells us about. So let us first get out of the way of this standard ERA procedure. Obviously, the ERA procedure which I am going to talk about has got multiple variations which we are doing at our, all of us, we have changed quite a few things. The standard ERA test comes, obviously, we have to change certain things, and that's really going to help us in our clinical practice. So let us first talk about the standard protocol. What happens is, to perform an ERA test, all you require is an endometrial biopsy with the help of Pipillay's catheter. You require relatively small tissue, say around 30 milligrams of tissue you require. To understand it simply, 1/5 of Pipillay's cannula, if it is full of endometrial tissue, that is enough. You don't need to take long strips of endometrium. If you take excess endometrium, obviously your test will not be correct. Now, based upon personal or clinical reason, this endometrial biopsy is obtained during either natural or hormone replacement cycle. Now here I want audience to understand that personally I do not recommend natural cycles. I only do HRT cycles, and whatever experience I have, in that less than 5% experience is only with the natural cycle. The rest 95% cycles I have done in HRT. And I've come to a conclusion that even though companies do tell us to have ERA test based upon either natural or HRT, I feel HRT is the most preferred way, and it should be that way. Now, in natural cycle, if it is collected in natural cycle, for the sake of consistency, it is recommended that ovulation is triggered by HCG when the follicle reaches 18 mm. Now you have a perfect, we have discussed the FET protocols recently. Now here, what we have to understand is when a follicle reaches 18 mm, we trigger it with HCG. And then the endometrial biopsy is taken 7 days later, 7 days after HCG. Also, once the trigger is done, after that, the progesterone is administered. It is administered in 2 doses, one in the morning, one in the afternoon. That is what is mentioned in standard protocol. We'll come to how we do things differently later on. Now, if the biopsy is taken at the HCG plus 7 in the afternoon, now please understand this. Here we have to take biopsy HCG plus 7. So when our follicle is mature at 18 mm and when we trigger it, then the progesterone secretion we have to start calculating 36 hours later, LS surge. So that is why when we administer progesterone, we will administer it HCG plus 2 days. The progesterone administration is done. And 5 days after that, biopsy will be taken. Now, regarding the specifics of if you take biopsy in the afternoon, when you should add progesterone, if you take it in the morning, when you should add progesterone, we'll come to that later. But simply we have to understand that endometrium must be exposed to progesterone for at least 120 hours. It is very important to understand that progesterone must be there for 120 hours and only then we take biopsy. Not even 1 hour less. We have to administer 120 hours. Now, personally, I would say go 123 or plus because you cannot possibly have exact 120 hours. So to be on the safer side, it is better that we calculate more than 123 hours. The HRT cycle, on the other hand, is a preferred choice due to its simplicity, consistency, and low cost. We do not have the worry of whether the follicle is there or not there, it is developing or not developing. HRT is very simple. You have to understand that we are going to couple it with IVF cycle, and again taking patient through those analysis, monitoring and everything really becomes stressful for the patient, and that is perhaps the reason why I don't advise natural cycle apart from many other hormonal reasons. Now in HRT cycle, the classic endometrium build-up preparation protocol begins with estradiol valerate at 6 mg per day. Now this is what a standard protocol mentions. Now I'm not saying we should do this. Standard protocol is 6 mg per day. We have had many variations to that and we will discuss about it later. Now between day 7 and day 10 of this HRT priming, we have to do ultrasound assessment of the endometrium. And when the endometrium is more than 6.5 mm and when the endogenous progesterone is less than 1 nanogram per ml, progesterone administration is begun. Obviously, progesterone is administered through vaginal route. Vaginal micronized progesterone is given. And 120 hours after administering the first dose, biopsy is taken. Now, in this slide, you have both the things clearly mentioned in a pictorial way, wherein on the first upper half, you have a natural cycle wherein you administer HCG. After that, administer HCG on 14th day, you have on 16th day, HCG plus 2, you add progesterone, and day 21, you take endometrial biopsy. Now you just see with the natural cycle, your endometrial receptivity analysis takes almost 21 days. While in HRT cycle, there is most often than not, the endometrium is ready in between day 9 to day 11. And then we move on to adding progesterone, and usually biopsies we are done away with by day 14 or day 15. So even if you go by the duration, HRT definitely wins hands down. I would not recommend anyone to go with a natural cycle route for other reasons as well, which we will come to it later. Now this endometrial biopsy, once we obtain that at least 30 grams of tissue, it must be transferred immediately to the cryotube. Now I'll be showing you that how that cryotube looks and all that, but you have to understand that this endometrial biopsy, it comes in a kit, and that tissue is loaded into a cryotube which comes along with that kit. Now once that tissue we transfer into the cryotube, it contains a solution which keeps RNA from degrading during the shipment. Now most important thing here you have to understand is the moment you obtain the endometrial tissue and you transfer to the cryotube, you have to shake that cryotube vigorously so that the RNA later fully penetrates the sample. It is very important. So how do you know vigorously and how much time? I will say just count 15. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15. Just count it till 15. Shake it vigorously. But before doing that, please make sure that you will cap it tightly. Otherwise, you'll end up spilling the solution. So you have to make sure that you shake it vigorously. And after that, this cryotube containing sample is kept in a refrigerator, not inside freezer, refrigerator. And you have to keep it at least for 4 hours. Now, please understand, all these instructions are given by, European nations and so on and so forth, who are not facing severe temperatures like us. So here, these things are, I would simply say that whenever you obtain a tissue, just keep it inside inside refrigerator till a person to collect that kit comes. Please do not bother taking it out of refrigerator and keeping it again at room temperature. It is not required. You just continue storing it inside a box, make a nice box for that ERA kit and keep on storing samples in that. It will be better. Now, why do I say that? It's simply because all these analysis, all of this information booklet which comes from are coming from countries which are not even having temperatures on the higher side of 20, while we are easily touching 40, 45 as well in some parts of India. Now, I had a bitter pill where a few years ago, most of my tubes got invalid results simply because there was too much heat, and probably during transport there was a problem. So nowadays, I even make sure that in month of perhaps May, I'm being very cautious about obtaining those samples when there is severe heat. It is actually better if we just skip that month, because we do get a lot of invalid results and then again patient has to go for repeat biopsy. And yes, when I spoke to a person who actually invented this test, Carlos Simon, he himself suggested that please avoid taking these biopsies during extremes of heat, so that even if we freeze it properly in our refrigerator, we cannot guarantee that during transport it is taken care of well. So as far as possible, avoid it. Now, this is how the ERA kit actually looks, wherein it comes with a certain box, it has got a catheter in it, and it has got other brochures. Now, I have made a small video lasting just 30 seconds, and I'll just explain it to you what you are seeing on the screen. This is a box which comes, this is the ERA kit.
In this
now,
kit,
I'll be taking out a pipillase biopsy from the box. What you see in front of you is a brochure and a pipillase biopsy.
This pipillase
biopsy we don't have to buy separately. It comes with a kit. It is really nice, and what you have in front of you now is a cryotube.
This is the most important box.
This cryotube is a small
solution.
Can you mute the original voice?
What we get is
the background commentary is also heard.
And we are supposed to collect the endometrial tissue inside this vial, and then we are supposed to freeze it. The pipillase biopsy catheter is given along with the kit, so we don't require any further assembly than that. There is also a consent form of the patient, and a lot of information we have to fill it up and we have to give to the company.
Yeah. So now what I will say is, what you see in front of you is a cryotube, a consent form, and a pipillase biopsy. Now please understand, this consent form, it has got every single detail of the patient, and that is what they require, because perhaps they are making more and more and more papers. They are collecting data from all across continents, and definitely they are interested in their data collection. As an Indian, I feel we also should be very aware of it, and we should keep one copy with us, and we should mention all we should put, while we are putting that data in those specific forms, we should also put that data in our own Excel sheets so that we also can review our own data. So this is how the small ERA kit, it comes with everything. You don't have to do anything. Now, the first procedure here is when you are going to send this ERA sample, first, when you are going to send it, you have to basically fill a custom form. That's a one-time procedure. So once you do that, then you are set, and then you just keep on sending the sample. Then you don't require anything further. Now, what exactly do we differently? Because I've mentioned, I kept on saying that, this is a standard protocol. So now I want to spend maximum time on this slide, that in this ERA test, how it is exactly differently done, considering our Indian scenario. So what do we do differently? So there are 6-7 points which we have to, now we are going to discuss in detail. And this is what is important. This is the beauty of Corodia Search, this platform wherein we can talk about our own experiences and exactly what we do differently. Now, I do not have the papers to show you. I have not published yet one of the endometrial receptivity assay data I have submitted to the Fertility Sterility Journal, but it is still not published. But what I can tell you is what I've learned in last 150 to 200 samples. This is what I'm going to share with you now. So the first point, customize endometrial preparation. Now, please understand, the ERA protocol mentions giving 6 mg of estradiol valerate. So many times, this dose is not sufficient. Now, why do I say that? I say that because when we are doing ERA testing, when we are using it in patients with previous history of chronic endometritis, history of Asherman syndrome, and all those patients where there is a thin endometrium, 6 mg dose sometimes is not sufficient. Now, in my initial series, I used to think that my results will change if I increase the dose, because that's not how the ERA test is designed. But then slowly what I did was I kept on changing the dose, and today even for those thin endometrium, I start at 12 mg for severely thin endometrium, and I do ERA testing so that when I'm going to transfer the embryos next cycle based upon the endometrial receptivity assay, I have a good endometrium. My focus is not just getting a endometrial receptivity analysis done. I have to remember that if that analysis comes receptive, then I will have to replicate the exactly same cycle next month. Now, in these patients where you have a thin endometrium, certainly 6 mg dose may not be sufficient. And then we are in a, we are in sort of catch-22 situation where endometrium is receptive, but our endometrium doesn't look good. And mind you, even then we have seen pregnancy, we'll come to that later. But regarding the first point, I want you to understand is nothing happens if you change the initial starting dose from 6 to 8 to 10 to 12 to 14, nothing happens. As long as you are monitoring these values well, there is no problem. Now, when do I say monitoring the values well? What I mean by that is when we monitor this endometrium and it reaches 6.5, 7, 7.5, along with that, I also try to monitor serum estrogen levels. Personally, I do not like to add progesterone unless and until serum estrogen levels are at least more than 150. Now, even 100 is sufficient, 120 is sufficient. I personally don't prefer adding it before 150. I feel a good estrogenic endometrium can only give you a good secretory endometrium. So I tend to believe in giving a good estrogen support in first 10 days. And that really helps us. Secondly, when we give more estrogen dose, what you will observe is the strength of that endometrium. When you are going for the next cycle, it will be better. Now, in that, this endometrial preparation, most important part is the second part of the progesterone addition. Now, just like first half I mentioned, that you need not go with what the company says, add 6 mg, you need not do that. Similarly, what I will tell you is, the protocols say that you have to give progesterone morning and evening. While I personally tend to believe that we have to administer progesterone 8 hourly. Hence, what I do is I administer progesterone 8 hourly. Now, those women who are working in office, they will tell you that, no, doctor, we are busy, we cannot administer the progesterone. And I will simply humbly tell them that then I cannot do ERA test. The reason for that is so many times when I monitored the progesterone levels in these women, adding just twice, just 2 vaginal doses, I found their serum progesterone levels were very weak. Not only that, it gave me good receptive endometrium, but that endometrium was not that much sensitive. What I mean by that is I did see, because of low progesterone support, I did see, miscarriages and all. So I feel that we must not shy away from changing the protocol. There is no problem. As long as you are sticking to the exact protocol and you replicate exactly the same way, there is absolutely no trouble. So usually what I do is I start with 8 mg on day 2 of the menstrual cycle. Usually by day 9, day 10, endometrium is ready. Usually you have minimum 7.5 endometrium. Now, when I say that minimum, I keep on monitoring progesterone levels right from day 8. And if the progesterone is lying between 0.2, 0.3, then I would actually tend to take that endometrium beyond 8 mm, 8.5 mm, even if that means the cycle goes up to day 12. As long as your serum progesterone level is under control, there is no problem. So you don't have to stick to the protocol saying, oh no, now it is 6.5, so add your progesterone. This is not same 2 + 2 mathematics. Here we have to use our Indian intelligence to make sure that how we can extract good information from this era. And here, what I say is you go on building the endometrium, just have a good look at progesterone, keep regular monitoring of progesterone. If you are not happy with endometrial thickness, but at the same time your serum progesterone levels are low, you can continue giving estrogen even for a longer period, no problem. Only and only when you are happy with the estrogenic endometrium, only then you should add progesterone. Otherwise, there is no point in wasting patients' money. That brings us to the continuous hormonal evaluation. I've already mentioned, we have to have a very close look at serum progesterone levels. So many times you will often find that your progesterone levels, if they are not monitored and suddenly you monitor them on day 12, and if the progesterone level is more than 1, then you have to cancel the ERA cycle. Because the principal prerequisite of doing this cycle, doing this test, is serum progesterone level has to be less than 1. Now, personally, I tend to keep it less than 0.9. I've had quite bad experiences beyond that, so I tend to keep it less than 0.9. Now, when I say that, it is very important that we must not be lazy in monitoring the progesterone. So many times what happens that the progesterone is somewhere around 0.9, 0.98, and then we tend to say that, okay, let me add progesterone. But what we forget is, if we are doing sonography in the morning, if we have obtained blood sample in the morning, then we are getting the results in the evening. By that time, the value which is 0.98 on paper has actually crossed the 1. And this practical aspect which we have to understand. So I would say, if you are taking samples and if you're monitoring progesterone for this era, try to keep a very strict control of less than 0.9, so that even if you have a progesterone, I'm not saying it is assured that by night it will not be more than 1, but chances are very low that if your progesterone is 0.6, 0.7, 0.8, chances are very low that by night certainly it will cross 1. So that's one thing I would really want to all of you understand. Now, when in this hormonal evaluation, when we put in, spice it up by saying that, okay, we are going to do endometrial receptivity analysis by natural cycle, then it really complicates game, because then you have to keep on monitoring LS surge, you have to keep on monitoring progesterone, you have to keep on monitoring follicle. But what we have to understand is, the moment we bring follicle into picture, we have something called as a dialogue between endometrium and ovary as well. Here we are behind the quest of solving the embryo endometrium dialogue. With the natural cycle, when it comes to play, so many times we will not like the Doppler flow in the endometrium, then endometrium is triple line, then your follicle is 18, but you don't like RI, so on and so forth. So what happens is, when we do natural cycle, things don't tend to match that perfectly if we have to do ERA in that. Natural cycle is a beautiful way of doing frozen embryo transfer. I do it a lot. But that is if you are doing it for embryo transfer. What happens is, if you do a natural cycle, if your endometrium comes receptive, replicating the same natural cycle next month is not easy. If you have good volume of IVF cycles, then you feel like pulling your hair with so many LH and progesterone levels. So it is better that for ERA test, you do ERA test with the HRT only. Now, third and most important cost-effective strategy. We are Indians. We must be very, very conscious about cost. We are not Europeans to pay so many rupees. So what you have to understand is, these companies are very clever. They will charge you roughly between 30 to 34,000 rupees for the test, and then there will be a transport charge of 4,500 rupees. What you have to understand is, if you have to do ERA test, please start a lot of ERA tests on one day. Please obtain 3, 4, 5 samples on one day, so that you end up cutting the cost. You don't have to pay 4,500 for remaining 5 patients, no? if you send 6 samples on a day, then you will end up paying only 4,500 for those 6 patients. So essentially, it will come to roughly around 700 rupees per patient. So patients will also save money, you will also save money. And more importantly, you don't have to pay a stupid company for that. It is not even going to this thing. So it is very important that you club a lot of samples so that you will save money and you will pass on the benefit to the patient. Now, please understand what I'm going to tell you the next. So many times, now I've been doing ERA for last couple of years, and I see that previously when the ERA was a new kid on the block, for every test where the repeat biopsies were asked, company never used to even charge a single penny. But now slowly they started asking for transport charge, this charge and that charge. They will ask 4,000 rupees, something like that. Nothing of that sort. If you're a good negotiator, you have to make sure that if you have done ERA test for your patient, and if the test has come asking for repeat biopsy, you fight tooth and nail and make sure that the next biopsy is actually done for free. Don't make patient pay, and for that you have to be a good negotiator. That's it. So these are the 2 very important cost-effective strategies which you have to understand, with which you can bring down the ERA cost a lot. Third and most important aspect of this cost. Most of the people in Bombay, what we have seen is even these prices are negotiable. The costing of ERA, if you club it with PGS, multiple embryos and everything, you have to understand that ERA is something which is a good cash cow for these companies. So they are open to negotiate. Their current investment in that project is not that much. They are charging you for the research they have done. So if you're a good negotiator, you may bring down the cost of ERA to right up to 28,000-29,000 as well. And it is very important, even though it's not a scientific part of the discussion, I feel that people who are going to begin ERA, they should know that you can definitely have a look at all these aspects. Fourth is counseling of the patient. Now I'll tell you the most beautiful aspect of a counseling of ERA is it not only you are doing counseling, you are actually giving somebody a hope. And it is not a false hope. It is not some false percentage. If you have a woman who is distraught with history of 3 previous failed IVF cycles, and if you just tell her that I believe that you can conceive, and perhaps my treatment strategies or whosoever has treated, my treatment or whosoever has treated, those strategies perhaps were not synchronized to your endometrium, and perhaps it is no fault of yours that you are not conceiving. Just imagine how much positivity you will give to that person. It is very important. That positivity alone, I don't know how much percent, how much those extra percentage it adds up to, getting that pregnancy positive. But I feel that you have to counsel patients ERA well. It not only gives them great confidence, but when you show a woman, and when the ERA test report comes, and when you sit with them and when you show them that, yes, look at the displaced implantation window, the couple, they are reborn again. They forget their failures. They understand that, okay, whatever happened, perhaps it is a displaced implantation window. More importantly, you stop stigmatizing that poor woman. Counseling is very, very important for that. Every time a woman is told, "Aapka uterus pregnancy nahi leta, bachchadani pregnancy nahi leta," that is a ridiculous statement to make. It's like telling somebody you can't see when they are perfectly good eyesight. So we have to understand that counseling of the patient is very, very important. Fifth and most important, compulsory replication of cycle. If we are spending patients' money and we are getting the ERA test, please understand you cannot have a different protocol next month. Say now you have added progesterone day 11 of this cycle. Now next month you have to go on a holiday. That is why you will now add it on day 9 or day 12. That doesn't work. What I'll tell you is, in a small series, I have even tried to change that. I did see that when we change even the days of progesterone, it really doesn't matter. But I feel it should be a matter of discipline that we must replicate the cycle exactly the way it is. Even if that means your embryo transfer comes on Sunday, you should be prepared to do it. Sixth and most important, cross-linking the experience with larger patient subgroup. Now, I want to understand this concept very clearly. All of us have a journey in understanding, learning, stimulation, just like similar to that. You will have your own journey when you start doing ERA test. Slowly, you will start figuring out subgroups where you will pick up, okay, this patient will have perhaps altered receptive window. Now, obviously, looking at somebody, you cannot figure out, but certain, commonalities when you try to make out and use your own clinical intelligence, I have seen that many a times we have been able to actually do error test even before doing IVF cycle, because we suspected that in a certain patient, yes, there could be a displacement. Similarly, you don't have to keep on doing error tests for all patients. Once you do these error tests repeatedly, you will actually start understanding that, okay, perhaps this group doesn't require. Okay, perhaps this my age group of 25 to 28, a normal responder, normal ovulating woman, perfectly beautiful endometrium, perhaps chances of displaced window is pretty less. Now, when you start gauging that, and there is a chance that you may fail even in that. I have failed many a time, but what on a larger scale, what you do is you can actually save few patients there, and you may give few patients there and you can actually save their failed IVF cycle. So it works both ways. So definitely we should cross-link the experience to the larger patient subgroup. Now, seventh and most important is matching your embryo time with your error time. Let us say your endometrial receptivity assay comes as 124 hours plus or minus 3 hours. You have to transfer embryos at 124 hours. And that 124 hours, let us say, comes at 11 a.m. in the morning or 9 a.m. in the morning. Then you cannot tell your embryologist to come at 9 o'clock in the morning. Ideally, you have to have the discipline of even thawing embryos exactly by matching the endometrium. What we have seen is when we freeze the blastocyst somewhere at around 118, 119 hours, when we thaw, we don't calculate first 2 hours, that's 0 hours. So when we calculate accordingly that and we transfer embryos, we tend to find better synchronization. Obviously, we have seen in an implantation window of 160 hours, an embryo of perfectly 120, 122 hours blastocyst matches. But yes, it is my observation that perhaps thawing properly synchronizing the endometrium window works better. Now here I want to put one more point, and it is very controversial, but that's my finding. I have seen that in endometrial receptivity assay cycle, it is always better to thaw embryos. Even if you have OD oocyte donor cycle, it is better to make embryos, freeze them, then thaw them. Now, why do I say that? We have spent quite a bit of time in talking about energy signatures. And I feel the fresh embryo energy signatures and frozen embryo, which is thawed again, perhaps there is some difference in energy signatures. I have seen that embryos which are transferred fresh in ERA cycle compared to embryos which were frozen, thawed, and then transferred, I have seen better implantation rate in the second subgroup. So my suggestion to you would be, if you are doing ERA test, anyways you are freezing the embryos. So kindly make sure that even for your oocyte donor cycle, you don't start fresh, you make your embryos, freeze them, and then transfer it as per the ERA test. This is what we do differently in ERA test. Now let us come to when we send the ERA test to the center, and when the reports come, how exactly the reports are interpreted. So reports are interpreted based upon whether they're receptive or non-receptive. Now for receptive, a receptive endometrial profile is divided into 3 signatures. One is optimally receptive, one is early receptive, and the third is late receptive. Let us come to first optimally receptive. Now here I want you to understand and picturize, all of you, that you are standing on a train station. Now you are standing on a beautiful train station and a local or perhaps train is coming. Now you do see that the train is entering inside this train station, but that train station is not on the platform. Now unless and until you are a Mumbaiker who has the ability to get into any train at any point, I'm talking about normal people. Now you just imagine that you are standing on a train station and a train is coming. Now when that train comes, just like you are in Switzerland and train comes, there is no crowd and you nicely walk into a train and you have a seat and then the train journey begins. That's your optimal receptive profile. An optimal receptive profile indicates the optimally receptive endometrium. In this case, it is recommended to proceed with embryo transfer in the same type of cycle on the same day in which the endometrial biopsy was performed. Meaning what? the train is standing right in front of you. That is optimal receptive profile. Second is early receptive profile. Meaning what? You see the train is coming inside the station, but it will still take some time for the train to reach you. That is your early receptive profile. Early receptive profile indicates that the endometrium is entering the receptive phase, but it needs additional 12 hours of progesterone administration in an HRT cycle to acquire optimal receptive profile. That means you don't have to run behind this train. You can let the train come to you and then you get inside it. For that, you just have to wait for 12 hours. That is early profile. The third is what? A late receptive profile, wherein a typical Mumbai wala scene, wherein local is about to begin and you have to run. So similarly, a late receptive profile indicates that the progesterone administration should be reduced by 12 hours in further cycle to achieve optimal receptivity. That means you have to start running little bit early. Now, receptive profiles are considered transition profiles, and it is recommended that personalized embryo transfer be performed after following the indicated treatment with progesterone without need for further verification. Means what? Ideally, they say that once you do the ERA cycle, then you don't have to go on monitoring your progesterone and everything, simply because in that cycle you have monitored your progesterone on day 9, you know it is not more than 1. If you maintain the same dose and keep everything same, then ideally you don't need further verification. Personally, I do hormonal evaluation even in the cycle when I transfer the embryos. So when we do the endometrial biopsy, whether we do it on LH7 or P5, when the endometrial receptivity test report comes, either it is receptive or it is not receptive. Let us see if it is receptive. That means what? Either it is early receptive, optimally receptive, or late receptive. Whatever it is, 12 hours before, 12 hours late, or right on time, there is a very good way of transferring embryos, and that is called as a personalized embryo transfer. Just like nowadays we are into boutique clothing, we want everything as per our fit. Similarly, we give a personalized embryo transfer fit. Let us say endometrium is not receptive. Then what? ERA test is not receptive. That doesn't mean the endometrium doesn't have the capability. Please understand this. Initially, I used to get scared when I used to see non-receptive endometrium. It is not like that. When you have a non-receptive endometrium, either it is pre-receptive or pro-receptive, post-receptive. In that case, sometimes you may have to repeat ERA, and then the report will come that receptive, and then you go ahead for a transfer. In last 150, 200 cycles, I have seen just one report where consistently we sent the biopsy 3 times, and every single time report came invalid. That particular RNA genome signature was not seen in the endometrial sample. Now, this particular patient was having history of pelvic tuberculosis. She had a very thin endometrium, and this patient had gone 5 failed IVF cycles before coming to me. Now, this particular, apart from this patient, I do not remember a single patient where either single or maybe in few cases required a second biopsy. After that report came and we did transfer. So what are the indications of ERA testing? Now, these are the indications which I follow. With my experience of doing these tests, more and more indications I have started including. That does not mean I do ERA test for everybody. No, I do ERA test in a very selected population, but these are the groups where I feel the ERA testing should be done. Number 1, recurrent implantation failure. Now, whenever we talk about recurrent implantation failure, we go on swinging our bat from good embryo to bad embryo, then oocyte donation, then embryo donation, and so on and so forth. But nobody looks at that poor endometrium. Okay, maybe this poor endometrium is perhaps desynchronized. So you have to understand that recurrent implantation failure is number 1 indication for ERA testing. There are multiple papers which have shown that recurrent endometrial implantation failure cases, the endometrium displays and exhibit a different transcriptomic signature than an endometrium which is receptive. Please listen to this. Cases where there is a repeated IVF failure, repeated implantation failure, that endometrium is definitely having different transcriptomic signatures than the endometrium where you have receptivity. Second is extremes of age group. Now I want you to understand, I have written extremes of age groups. Why? simply because I have seen that patients who are more than 40 and patients who are less than 25, or I will say less than 23, please be very careful. Now you will ask me, why will you do IVF for a 23? I agree. But all of us, we have had those few rare patients where sometimes in young age also, so because of certain problems, we have to do their IVF. Now in those cases, I have seen that chances of displaced implantation window is very high. Now, when you have a 40 or plus woman, your expectations also, as well as that person's expectations are low. So they know even if cycle fails, okay, probably there is some problem. But for a young patient, they do not accept. And so also you cannot accept. So that is why I feel in extremes of age group, we have to be careful, and in selectively, we have to apply error testing. Third is PCOD. Now, this particular part I have seen, I was frustrated seeing bad results in PCOD. Fresh transfer result, frozen transfer results are much better in PCOD, but fresh transfer, I used to be frustrated. Then what I saw that in severe PCO patients, even in frozen embryo transfer, certain patients, even I was not getting pregnancy even frozen embryo transfer. Beautiful endometrium, beautiful blastocyst, yet no pregnancy. All those PCOD patients, when I subjected them to error test, I will be showing you the reports later, we did see certain surprising figures. And once you see them, you will realize that yes, perhaps this is a different ballgame altogether. Fourth is premature ovarian failure. Now, I want you to understand that the moment premature ovarian failure happens, the woman is subjected to oocyte donation. And the oocyte donation is given, and when those so-called beautiful blastocysts will transfer in woman's cavity and she doesn't conceive, then she is stigmatized even further. Till now, her ovaries were bad. Now, her endometrium is also bad. This is not her fault. The problem is because of premature ovarian failure, we have seen that this particular endometrium also changes its receptivity profile. And we have to be very, very careful in these patients. Just like the ovary has taken an early start, her uterus also takes an early start and it changes its receptivity profile. Fifth is severe endometriosis. Now, recent ASRM ESHRE data says that endometriosis does not have any sort of effect on implantation. In my small clinical practice, I have seen that yes, in selected patient in endometriosis, whenever I send their error test, I have seen some really surprising figures. So I have kept that indication that severe endometriosis is definitely an indication. Now, there is one more reason for this, is you have a bad oocyte quality. Very rarely it happens, but you have a bad oocyte quality, patient undergoes 2-3 endometriosis IVF cycles, and then somebody suggests her oocyte donor cycle. Now, don't you think a poor woman who has undergone 2-3 failed IVF cycles, if she is getting subjected to a further advanced treatment, at least we should try and ensure one arm of that, we should try and secure one arm of that procedure. To have a pregnancy, you just have to manage two things. One is endometrium, one is embryo. Now, when I'm saying just what, it's out of, it's a sarcastic way of expressing. But what I'm saying is, if we are going for a oocyte donor cycle for a woman, we have to make sure that we do everything in our capacity so that cycles do not fail. And if so is the reason that poor implantation window is at a problem, we might do something, find out the implantation window and then transfer, rather than making a prestige issue and putting that woman under down regulation months together, transferring embryos same day, plus here, plus there, and it doesn't work. Sixth and most important, Asherman syndrome. Now, please look at all the indications. We have mentioned about ATP, we have mentioned about heat signature, we have mentioned about gene upregulation. Please see that Asherman syndrome, a poor thin endometrium. Don't you think that energy signatures will be different in this endometrium compared to normal? It has to be. And we have seen multiple cases where in Asherman syndrome, there was a displaced implantation window. Then you have Mullerian anomalies. There are case reports where, you have one implantation window in one horn and, bicoordinate uterus, and in another horn, there is another implantation window. There are case reports, I will show you. So it is not that even one uterus has same implantation window. If you have two horns, there is a chance that one horn has a different implantation window and another has different one. Previous history of tuberculosis. Obviously, the European nations are not going to tell us this indication because they don't have one, but we have. Tuberculosis patient I have seen, history of tuberculosis, please do endometrial receptivity analysis. Whichever company, what product you choose, that is totally up to you. I'm talking about where you should do endometrial receptivity analysis. 10th indication is very obese patients. Now what I've seen is normal BMI patients and perhaps I would say little overweight patients, they don't have these problems. But if you have very obese patients, usually it is coupled with severe PCOD, insulin metabolism disturbances, and all these three on their own, that is PCOD, irregular, I would say disturbed insulin metabolism, and very obese patient, they have scientifically it is proven that they have displaced implantation windows. They change the energy signatures in the endometrium. So that is why I'm including this. Last is previous multiple uterine surgery. If you have a patient of adenomyosis, please try and think of doing that, because most of the times you will find in these patients there is a displacement. Now when I mention these indications, obviously a thought will come to mind that what is the proof that recurrent implantation failure requires this? So here is the proof. Now for all these indications, if I go on quoting papers, we will spend next 12 hours in just quoting papers. So I'm trying to be specific in terms of showing you a good quality articles which will show that yes, there is a problem with transcriptomic signature. So here is a beautiful paper you see in which they have shown that recurrent implantation failure is a pathology with a specific transcriptomic signature. Please understand this. Recurrent implantation failure is a pathology with a specific transcriptomic signature. When I say specific, it essentially means it is different from a normal implantation, normal woman. And to understand how different it is, we have to do endometrial receptivity analysis. All these papers, full versions, if you require at any point of time, after discussion, I will send surely post it on group. You can go through it in detail. Now here, in this, I have taken some notes. You see, in this recurrent implantation failure, when the window of implantation was studied, they showed that approximately 26% of those recurrent implantation failure patients had displaced implantation window. What I mean by that is if you have 26% displacement, that means what? If you have 10 recurrent implantation failure patients, at least 3 of them are having displaced implantation window. Rest 2 may have even more, but this is at least. Now here, the more importantly, out of these patients, when the correction of that displaced implantation window was done, 50% of those cycles could be rescued. Patients up to, in my clinical practice, I have seen patients up to previous 6 failed IVF cycle conceiving after finding out the correct implantation window and going ahead. So you have to understand that endometrium is more than just receptive. When we say that we transfer the embryo on day 5 and we don't go beyond that, you have to understand that it is not only about endometrium being receptive, it is also about being selective. That is why this beautiful diagram, if you see here on the left side, I know the print is a little bit small, so probably you will not be able to see it clearly, but I will surely send the paper later on. On the left extreme of the graph in the figure, you have seen very high receptivity, but very low selectivity. What happens then? Endometrium is beautifully receptive, but badly selective. So even if embryos get implanted, there is a recurrent miscarriage. Now please understand, this is one end of the spectrum where the endometrium is receptive and yet it is less selective. On the other side, you have another extreme wherein endometrium is highly selective but low receptive, wherein you will have recurrent implantation failure. Beautiful blastocyst, you transfer, doesn't work, you are on the right side. Beautiful blastocyst, you transfer, miscarriages on the left side. I am not taking away other factors which are important for recurrent miscarriages. I am just concentrating on endometrium. And what I mean by that is this endometrium is more than just receptivity. It is also about selectivity. Then
Dr. Chinmay, sound is cracking in between. So kindly correct the mic.
Okay. Can you hear now, sir?
Yes.
Yes. Yeah. Am I audible clearly now?
Absolutely.
Okay. So the next paper which I'm going to show you is how obese women tend to have displaced implantation window. Now here I have already told you in my personal finding as well, I saw that if you go to a last paragraph, it is written that the incidence of non-receptive endometrium was higher in obese and morbidly obese patients compared to normal weight and overweight patients. Now here, listen to it importantly, next part. In addition, a significant endometrial gene expression alteration during the optimal window of implantation in obese patient was recently reported, highlighting the idea that energetic metabolism is also important. Means even in the receptivity phase, your energy signatures also change. And in these obese patients, definitely it poses a risk of being non-receptive. So we have to be sensitive to that fact. Now, here is another paper which shows that yes, increased body mass index, it does affect endometrial gene expression patterns in infertile women. Now you will say, I have seen so many obese women conceiving naturally. That's the difference, what I'm saying. I'm talking about patients who are infertile. Obese with infertile, severely obese with infertile, insulin metabolism disturbances with infertile. These are the specific groups where we are finding there is some problem in the endometrial receptivity. That does not mean we attach the same template to a normal fertile woman who is obese, who is having insulin metabolism. No. Just like a PCOD woman who conceives naturally may not have any problem. Similar to that, we cannot attach this template to a fertile woman. This is for infertile women with obesity. They have shown that yes, definitely there is altered gene expression. Does insulin resistance correlate? Yes. Insulin resistance also correlate with the endometrial transcriptomic signatures. You now look at the pattern. You have obese patient, PCOD patient, infertile patient, insulin resistant patient. They are nothing but all parts of the same prism. We are just trying to look at it in a different way. But what passes through it is endometrial receptivity. And that definitely we feel that insulin resistance is related to the endometrial gene expression and endometrial receptivity. Now, this is what I was quoting before, wherein uterine didelphys, there is a different endometrial receptivity. Now, why it is important to understand that? This just underlines the fact that if we are not accepting that uterus has a so-called implantation, window of implantation, if we are not ready to accept that, how do we explain a uterus which has got two horns having these two different windows and with a previous failed embryo transfer? So it is important to understand that these Mullerian anomalies, these, the criteria which I mentioned, definitely there is altered implantation window and we have to be sensitive to that fact. So coming to the ERA test, is it really effective? I feel yes. What does data say? So this was a paper posted, presented way back in ASRM conference. Again, the same group of Carlos Simon, they had presented, and they showed that out of 12,000 patients, now please understand this data, 12,000 endometrial biopsy patients, 71% patients were receptive and 28% were non-receptive. Okay. These figures are again further, it is backed by various papers even from India. Dr. Nalini Mahajan, Dr. Manish Bankar, in their own papers, they have shown somewhere between 23 to 27% patients are non-receptive, while around 70-75% patients are receptive. All these non-receptive 27-28% patients, in that what they found was 12% patients were post-receptive, while 85% patients were pre-receptive. That means there was some sort of alteration of a window, but in 12% patients, there was severe alteration. All those patients can actually be rescued. So what exactly is personalized embryo transfer? Let us summarize it again. In normal fresh embryo transfer cycle, you make embryos, you transfer them in your uterus. In deferred embryo transfer, what you do is next month or perhaps next to next month, you cryopreserve embryos and then you thaw embryos and put it based upon whatever protocols you follow. In personalized embryo transfer, what we do is we make embryos, we freeze them, and then we find out an ERA, we find out an implantation window, then we thaw embryos, and then we transfer. So what was the result in their finding? they found that out of total patients they have recruited, which was roughly around 500 patients, almost a similar number of embryo transfers were done in all three groups: fresh embryo transfer group, deferred embryo transfer groups, and personalized embryo transfer group. Now, in that, what they found was column 1, pregnancy rate. Pregnancy rate was significantly more in personalized embryo transfer group. Why is it that if you just calculate the percentage of fresh embryo or deferred, it is lying around 60%, while you have a personal embryo transfer which is around 25% more, that is 85. So all those 20-22% patients would be rescued. I'm not saying in the same cycle. I'm saying the pregnancy rate per embryo transfer was 85%, which is, I feel it is fantastic. Similarly, they found that ongoing pregnancy rate as well was more. Now here is what I mentioned to you before. You remember that slide where I mentioned about selectivity and receptivity of the endometrium. These are the two hats endometrium wears at the same time. When we are transferring the embryos at the time when it is receptive, if it is even better selective, and if the equilibrium of that selectivity and receptivity is there, then perhaps even the ongoing pregnancy rate is also more, which is clearly shown in this table. This is my interpretation. You can have, the more you think about it, you will find even more aspects to this. Now, in this particular study, like I mentioned to you before, they have shown this, and I will post the detailed charts of this study if anybody is interested. But what you can see is group A, group B, and group C were there in fresh embryo transfer, deferred, and personalized embryo transfer group. And definitely in column number 4, pregnancy rate per embryo transfer, it was definitely significantly more. Similarly, to that, the differences in implantation rate and pregnancy rate between both groups was highly similar to those found in previous research. That means 23% of pregnancy rate and 13% of implantation rate in FET versus 60 and 45% when the personalized embryo transfer was done. You look at the clinical outcome and efficiency of embryo transfer slide, which is in front of you, you will see there is a significant difference between these two groups, and we will discuss about it a little bit later. Now, if we look at the endometrial receptivity, this is also a very interesting paper where, they have, this paper is by Dr. Nalini Mahajan, and she has shown that the results in Indian population also reveal that endometrial factor in almost 28% recurrent implantation failure patients, which was significantly greater than non-recurrent implantation failure group, which was 15%. So definitely even in our Indian scenario as well, there is definitely clinical application of this test. Now, when we talk about ERA and when we attend the conferences, these two things are most commonly discussed. And I thought that let me first approach the controversies and then talk about other facts. So these are the two main controversial aspects of ERA. One is, does it change from one cycle to another? And second, does scratch itself changes anything? Now I remember this very famous incident in ESHRE where somebody meant to say that when you scratch endometrium while doing the endometrial receptivity, perhaps that procedure than the endometrial receptivity assay test improved the implantation in successive cycle. Quite possible. Let's see whether it is reality. So the first claim, does it change from one cycle to another? Now this chaos started with a paper I would say published in 2018 in Journal of Assisted Reproduction, where they showed that a 44-year-old woman had intra-patient, means in her different menstrual cycles, there was a variability in endometrial receptivity assay. Now this paper led to a lot of people believe that perhaps that is why ERA doesn't hold the water.
Again, your voice is cracking, Dr. Chinmay.
Yeah.
Please take care.
Yeah. Till now it was fine, sir?
Yes, fine.
Yeah. Now, intra-patient variability in endometrial receptivity assay. The storming cup was basically brewed by this paper, where they showed that a 44-year-old woman had different endometrial biopsies in different menstrual cycles, and they showed varied results. The basic problem in this paper was in front of you. If you see here clearly in the summary of ERA results, which is quoted in that paper, you go to #1, wherein you see duration of progesterone P4 supplementation when biopsy was performed. You see it is 106 hours. Now, the beginning itself of this paper was wrong. And this paper was criticized later a lot because the biopsy itself was performed at a wrong time. Not only that, even the second biopsy was also performed at a wrong time, because when the first biopsy was performed, which was 106 hours, the report came that you have to now do the second biopsy at 154 hours. But even the second biopsy, which was done almost 40 hours later at 194 hours. And that is why the entire discussion started happening that, does it really change? Intracycle variability happens or no? But apart from this, there are many papers which have shown that even after 6 months, even after 6 months, even after 1 year, even after 2 years, even after 3 years, endometrial receptivity does remain the same. In countries like Spain, where they do ERA testing as a standard procedure along with IVF, they have shown that a woman who had a successful IVF cycle with ERA test came back 2 years after, again had a second set of embryo transfer, and then she conceived with the same result. So clearly, this intracycle variation requires further analysis, but you have to also understand that intracycle variation can also happen because of a host of other factors, because of hormonal changes, because of weight changes, because of so many things. Now, certainly weight doesn't change in month-on-month basis, but if somebody is repeating the test after 6 months and somebody has gained weight in those 6 months substantially, then yes, there is a scope that endometrial receptivity might change. So does endometrial injury affect? No. Here is the paper in front of you wherein they have shown the transcriptomic signatures, and they have shown that it does not change. Endometrial injury, what it does is it changes probably the senescence of the endometrium, and the natural killer cell activity, gets upregulated, and that is why implantation, all those theories, more and more data, even the Cochrane is not accepting that endometrial scratch is a way forward for all patients. So definitely endometrial scratch per se has got no relation with endometrial transcriptomic profile. These two are different things, and I feel they should be looked at from a different angle. Why? Because let us say if we do ERA test in this month, now endometrial scratch has happened in this month, and if I transfer embryos after 6 months also, they have shown that this with the same implantation window transcriptomic signature, pregnancies have happened. So perhaps the endometrial injury primarily does not affect the endometrial transcriptomic profile. Now I'm coming to the most significant and most interesting part of the discussion, and that is my personal reports, which I will show. Now here you have a patient who is 37 years old, who is having beautiful receptive endometrium, to perform blastocyst transfer at 124 plus or minus 3 hours of progesterone administration, that is receptive. Wow, 37-year-old woman, fantastic, having a receptive profile. Second paper, you have a 43-year-old woman. How do I say her age? Look at the left column, patient's date of birth, 14th October 1977. So you have a 43-year-old woman, again beautiful receptive endometrium. You are even happier. Why do we need endometrial analysis? Now third patient, you just have a 30-year-old girl. Again, she's having receptive endometrium of 125 hours. Beautiful. So a 37-year-old, a 44-year-old, and a 30-year-old, these three different age group patients have increased my confidence like anything in thinking that perhaps my protocol of embryo transfer works in all patients and I don't need ERA. And here comes your googly. This patient, she is approximately 44-year-old, Sanjana Gaikwad. This patient before coming to me had previous 6 failed IVF.
Voice is cracking, Dr. Chinmay.
Yeah, even now it is breaking, sir. Just a minute. मतलब headphones देगा.
Then immediately get corrected, but in between again something happens, then it starts cracking.
Okay, is it okay now, sir?
Because these are very important discussions. That's why.
Yes.
Yeah, now
Yes.
it is okay.
Yeah. So now this patient is 44-year-old patient. Okay. And now you have a displaced implantation window. This patient had come to me with previous 5 failed IVF cycles, and the displacement was just around 12 to 15 hours. Now here it is written receptive. Now that's what I was trying to tell you, that now when I use my clinical experience for these patients, and when I take their ERA biopsy, not at 120, but I play a game where I take biopsy at 135 hours. Then what happens? Then suddenly I see a receptive endometrium. If I would have obtained this biopsy at 120 hours, what a protocol suggested, perhaps I would have had a different result. But that also would have mentioned, perhaps asked me to take a repeat biopsy, which is not good. So what I'm saying is, when you are taking endometrial receptivity biopsies, you can even program it with your own experience. You don't have to obtain it for 120 hours exposure only. Sometimes you can make an exception and you can, expose the endometrium for 135 hours as well. Is voice all right now, sir?
Better, but not
Yeah.
completely all right. Yeah, better.
Okay. Now, this is the second patient in front of you. This patient is 35-year-old. This patient is South Indian patient. Look at her endometrial profile. She's pre-receptive. With embryo implantation, personalized blastocyst transfer should be performed with 150 hours. Please see this. Now, how will any person, any fertility specialist can gauge an embryo implantation window of 150 hours? We transfer embryos at 120 to 130 hours, right? This patient her endometrium was deep asleep at that time. Her endometrium awakens at 150 hours, not before that. Then what? Next slide. This patient, 38-year-old, again, 148 hours of progesterone administration is required. You can see whatever I'm reading is in front of you. You see, now I had shown you initially a 37-year-old receptive patient. Now you have a 38-year-old patient with pre-receptive profile. What is the difference? This patient, Swati Patil, is also suffering from severe endometriosis. Next slide. This patient, another South Indian patient, around age 40 years old. Look at her profile. She's pre-receptive with personalized embryo transfer window of 160 hours. Now, there is no way in this world wherein we can know somebody's implantation window, progesterone administration should be 160 hours. We'll keep on transferring embryos between 120, 130. Sometimes if we get desperate, we might just postpone it by a day, saying that, okay, we will transfer it at 144 hours. But even then it would not have been sufficient, because this patient had blastocyst, a personalized embryo transfer window of 100 and close to 60 hours. Whatever reports I'm showing you, every single person has conceived with me and they have delivered with me. Only those reports I'm showing, not the current cycles which are undergoing, those who have not delivered. Now, the next patient, Savita Adkar, she is 36 years old lady. History of previous pelvic tuberculosis. Now, her personalized embryo transfer window is 135 hours. You will see a lot of patients are having early receptive defect, which is actually collaborated by papers as well. That most of the patients will have, roughly those who are having displaced windows will have either early receptive or late receptive windows. Very few will have post receptive windows. Come to the next point. Priyanka Saban. Now look at her. She's just 33 years old with again personalized embryo transfer window of 132 hours. Now, this is the most important slide I feel. This patient, Padmaja Karnik, when she came to me, she was around 42, 43 year old. This patient previously had a natural conception. Before coming to me, she had a previous history of childbirth. This was her second marriage. We thought that patient, since she's falling above 40, let me do ERA. Boom, result is in front of you. Personalized embryo transfer should be performed with 111 hours. Now, one more thing I forgot to tell you is, before coming to me, this patient had undergone 2 IVF cycles. And both the cycles had failed, wherein the clinician was confident, thinking that this patient had conceived naturally, so all I have to do is make embryos and transfer. But it did not work. Now, all along, the assumption is embryos were of good quality. And during this discussion, we have to keep that assumption going, because we are concentrating on endometrial receptivity. So here, a fertile, completely normal patient is having an implantation window of 111 hours. The next patient, very interesting. Now you have a late receptive patient where implantation window is just 101 hours. Now just imagine you have to transfer blastocyst at 100 hours. Now what was different, so special about this patient? This patient, I had operated her for myomectomy, and perhaps 4 months after that, I had taken her ERA test, and after that I had gone for IVF cycle. So the result is in front of you. Previous history of uterine surgeries. Please think of displaced window, not in all, but at least in selected. Another patient in front of you, same patient, who was around 40, 44 year old. She's late receptive, where I thought that maybe her implantation window was displaced. So I transferred, I administered progesterone and I took biopsy at 135. But here the nature was kind to her, and it showed that her endometrium was actually 121 hours. So it works both ways. Not always we are correct, but yes, so many times we can have a gauge by looking at the age and overall condition of the patient. Now, this is another patient who is very young again, just 28, 29 year old, but she was suffering from grade 4 endometriosis. So naturally, my inclination was maybe this patient is also a good candidate where endometrium implantation window might be displaced. But that was not the case. In her case, the endometrial exposure of progesterone was a progesterone of 120 hours was sufficient. Now, I'm taking you to the most important slides, that is post-receptive profile. Please look at them very carefully. This patient, before coming to us, had previous failed IVF cycle. We do her ERA test. We send endometrial biopsy after approximately 120 hours, 123 hours of exposure. And the report came asking us to do repeat biopsy at 99 plus or minus 3 hours. Such was the case. Second, such was the case. Now, I'm showing you one more report. Poonam Galial. Now, this patient, 40-year-old. The reason I'm taking names of the patient is, in our clinical practice, we are used to calling patients subjects, and we tend to lose sensitivity towards them. A poor lady having 3, 4, 5, 6 failed IVF cycle. Everybody tells her, I am God, with me you will conceive. Report is in front of you. Patient having 7 previous failed IVF cycle. We sent, this is one report in front of you. We sent her successive 3 biopsies. Every time patient's report came non-informative. This patient simply lacked the genetic expression profile which is required for implantation. This is the case I was talking to you about, that this one patient I have seen where there is, even those things exist. But here, at least you can counsel her to go for surrogacy rather than torturing her for multiple embryo transfers. Because anyways, patient was having thin endometrium, but the patient was not ready to believe in that. But when you show the report to her, saying that her endometrium is also non-informative, that time patient also can have an emotional closure towards cycle. Patient can understand that yes, perhaps IVF cycle treatment is not correct for me. I have to go for further treatment option. So just imagine a report actually works so much for a patient. Even a non-informative report can do a lot of favor to patient by preventing her into going for unnecessary cycles. Next patient in front of you. Again, a young girl, just 32-year-old, severe PCOD patient, obese patient. Look at the endometrial receptivity profile. Post-receptive profile, 95 hours. They are asking us to perform a new endometrial biopsy of 95 hours. When we did that, report indeed came at 96 hours or something. The patient also conceived. Again, one more patient of severe PCOD in front of you. Look at the age column. She just 26 years old. When she came last year, I did so perhaps 24 years old. Look at the implantation window. A 24-year-old girl having an implantation window of 99.3 hours, where the repeat biopsy was recommended. We did that and report was confirmatory according to that. Who would have thought a young girl, 24-year-old, can have a displaced window? But yes, these are the patients where for no rhyme or reason our cycles keep on failing, and perhaps here we are having a problem at the endometrial receptivity level. Now, look at this patient. She was another sweet lady, just 20, I would say in her 30s, severe PCO patient again. She was patient enough allowing us to do biopsies. At the end of third biopsy, wherein the report kept on telling us to obtain one more biopsy, this is what we reached. And that endometrial implantation window was 100 hours. Now, in none of my teaching, I was ever told that blastocyst has the ability to get implanted at a 96 hours of progesterone. Now, we all know endometrium can accept any blastocyst, but how many of us can actually foresee that an endometrium can accept a blastocyst at 96 hours, 97 hours, 100 hours? I think it's impossible, right? So that is why we need to have a selective approach and use those. Now, this is a new kid on the block. As if to fry our brains, endometrial receptivity, puzzle was not enough for nature. Nature threw us even more things in research. And then came the Emma and Ellis test. These are the new things again, which analyze about endometrial microbiota. It also analyzes about chronic endometritis profile. And it gives us information about what sort of antibiotic treatment do you need to give to your patient before transferring embryos. How many days of probiotics are needed to give. Now, what does that tell us? These energy signatures, gene upregulation are also perhaps controlled by something external or perhaps something internal, that is endometrial microbes. So what we have to look at it is the research is still ongoing. These two things, Emma and Ellis, these are new things. When you combine all Emma and Ellis, the test is called as the EndoTrio. I have sent 3 or 4 patients till now. The test is very costly, cost approximately 63 to 65,000 rupees. So in a very selected cases, I have sent. Now here you have to understand that this Emma test, in Ellis test, even though they do not mention about tuberculosis, when I spoke to those people, they said that they did see that and they can report tuberculosis. The tests are designed in such a way that if tuberculosis is there, definitely they can report. That's what they have told me. So what are the limitations then? Now you have to understand limitations are, first of all, the limitation is the temperature range, the storage problem, and sterility. We have to be very, very careful about that. What I told you, I've had a very bad experience in month of May 2 years ago, where a lot of patients I had to do repeat biopsy. So make sure that the storage facilities are correct. Second is error test. It involves replicating the type of cycle. Okay, so this is a limitation. If we are not ready to replicate, then error is useless, I feel. Third, endometrial assessment only accounts for the assessment of endometrium at transcriptional level. However, other possible changes may be present, such as an altered uterine microbe, which may impair the clinical results of otherwise receptive endometrium. Not only synchrony, but also a chromosomally normal embryo is needed for a successful implantation. So for perfect marriage, you require both husband and wife. Otherwise, nothing is going to happen. Now, just like transcriptomics, the second newer kid on the block is proteomics. Now, to develop a complex view of endometrial receptivity, we must move beyond transcriptomics. Proteomics are the next step in the evaluation. Proteomic analyzes what really happened at the tissue level, and it will reveal about molecular changes that happen at endometrial level. Means what? There are almost 32 different expressed proteins in receptive versus pre-receptive endometrium. But main two, which are very, very important for cytoskeleton integrity, are annexin A2 and stabmin 1. Just like a few years ago, we did not know about endometrial receptivity hours, but now we know similarly.
Your voice cracking, Dr. Chinmoy.
Yeah.
Again, voice is not clear.
Okay. Now it's fine, sir?
Yeah, it's fine.
Yeah. So just like a day where, era seemed impossible, number of hours seemed impossible, a day will surely come in future wherein we will exactly know the signature pattern of these two proteins as well. And I feel it will help us in analyzing the endometrium. Proteomics have also been used to analyze endometrial fluid to study endometrial receptivity. Now, endometrial fluid secretion undergoes significant changes in protein content during transition from proliferative to secretive phase. We all know that. Now, obviously, that endometrial fluid will contain vast amount of information about implantation. There are various studies which have, like I told you, have also gone into lipidomics. And they have shown that in endometrium, there is a specific lipid composition which is predictive of endometrial receptivity. A significant increase in PGE2 and PGF2 alpha is seen during window of implantation. Now, please understand and understand this clearly. I know it is a long presentation, but we are coming to an end. So please pay attention. There is a significant increase in PGE2 and PGF2 alpha is seen during window of implantation. Their concentration in endometrial fluid aspirated just 24 hours before embryo transfer can predict pregnancy outcome. So, why do we think it is important? What happens when there are chronic synecdoche? What happens when there is chronic inflammation? What happens, when you put intrauterine barriers? Don't you think at that time the prostaglandin secretion changes, which in turn affects the pregnancy? Because it affects implantation. So on the similar lines, we also can, perhaps a day will come where in our own Indian clinical setup, we'll be able to obtain endometrial fluid, check for their PGF2, F2 alpha levels just 24 hours before. And if and only if, just like we monitor serum progesterone levels on day 3, day 4 now before transferring, similarly, this will be one of the most powerful tool if proven that way, which will come handy in terms of improving our results. So what is the conclusion? Conclusion is synchrony between major players in the implantation process has been proved to be one of the critical factors contributing to the success of assisted reproductive treatment. The embryo must be viable, but even with chromosomally normal embryos, the human embryo implantation has the low level of efficiency, reaching only up to 50-60%. In variety of endometrial thickness and pattern, no matter what thickness you have roughly around that much efficiency. Maternal endometrium is clearly an important limiting factor, and it should be incorporated into calculus of assisted reproductive treatment. So with this slide, I conclude my presentation, wherein I want to mention about few facts. Number 1, is ERA required for all? If your patient is ready to do it, please do it. Don't shy away from it. you, by trying to find out the implantation of window, doesn't become a small clinician than what you are. The treatment is not about you, it is about patient. And every single act of you should be dedicated towards success. In that, nowhere I mention that we must fall prey to the commercialism. I am not saying that. I am saying that this endometrial receptivity analysis is going on now for now close to a decade. More than 40,000 IVF cycles have been analyzed, have undergone. But I feel we have to embrace this technology going forward, simply because just like in olden time when mother used to have three abortion, even till then medicine did not advise any investigation. A recurrent implantation, recurrent miscarriage was defined as 3 or more abortion. And now in 2020, we don't even accept one abortion. Similarly, if not for all patients, at least if your cycle fails after you doing your best, you should keep one eye on endometrial receptivity, and maybe by doing that, we will help few women from getting stigmatized by being called as a so-called endometrial dysfunction, rather than accepting our failure of endometrial desynchronization. I thank Coradia sir, I thank audience who have been patient to listen to me. I have tried my best to explain, and now I hand over to Coradia sir.
That was a brilliantly presented presentation, and I don't think I have not heard anybody elaborating this subject to this extent, and it has given a lot of insight and a lot of thought-provoking points. Really, it was a fantastic, amazing. This was one of the best presentations till now on this platform. Really thanking you for that. And now we take up the questions.
Yes.
So first of all, we will take from the chats.
May I add something? May I add something,
yes,
sir?
Please.
My dear friend Jay, now I will certainly not look, try to have that mental. My dear friend Jay has also done substantial amount of work in ERA, and if he is online and if he feels that I have missed few points, I will invite him also. If he wants to say something, let him also join us, so that
I think he has left a couple of minutes back, if I'm not mistaken.
Okay.
Dr. Jay has left a couple of minutes back only.
Okay.
Okay. So from chats, let us see. Dr. Mahesh Jariwala, he said, okay, he is thanking you for clear presentation, basics clear.
Thank you, sir.
So first,
thank you.
I'm going through the chats. Huh?
Okay,
first
sir.
of all. I think chats are clear. Now coming to the questions.
Yes, sir.
Dr. Sarath has some chat. He's also thanking you. Super excellent talk, sir. Thank you very much.
Thank you, sir.
Okay. Now, 1+60.
Yes, sir. Myself, Dr. Deshmukh, sir. I would like to know when the patient is ERA is non-informative. Do you counsel the patients earlier that you may have to go for a repeat ERA?
Yes. So please understand that counseling of the ERA test is very, very powerful tool, not only to help patient in understanding about their own fertility, but madam, since you are a woman and you are asking me this question, what I will just deviate a little bit and I will use this opportunity to explain it a little bit. Just like those two pink lines saying that this woman's endometrium is receptive when she has undergone 3, 4, 5 failed IVF cycles, I think it gives a great degree of confidence. And in return, any woman will allow me to do 100 repeat biopsies, forget one. If a woman is allowing me 3, 4, 5 repeated IVF cycle, will she not allow me to do repeat biopsy? Absolutely yes. So I may not be very, very categorical in stating and making her fear about it, but I would rather keep it under wraps. And if rarely, like I said, very rarely we get report of repeat biopsy, if that happens, then we tell a woman in such a way that she understands it. I tell her that I need one more sample because the window needs to be focused even further, and they happily allow. We have never seen problem in that.
Then is there any concession for the patient if she has to go to a repeat ERA or from the company side as well as from our doctor's side?
It is free. It should be free, and that should be your duty. That even the let us say you have you have a patient of repeat ERA. What I do is I don't check anything for sonography and everything. If the patient is from a socio-economic poor background, let us say relatively, and what I do is I tell the company that you do it, make even transport charges free. I tell them, and so many times they listen. So it is totally up to you how much bargain. Just like for FSH, you bargain, no, madam. Similarly, you have to bargain.
So as they say that some of the times you have to transfer at 111 hours and the blastocyst we transfer at 120 hours. So it will be depending upon this receptivity only, which will give you a good result. Huh?
See, now if 111 hours, like I said, endometrium is both selective and receptive. You may be transferring embryos in a receptive endometrium which is not that selective, or you may be transferring embryos in a endometrium which is selective but not receptive. And in both the ends, you saw what happens. So what ERA gives you is actually both selectivity and receptivity. So I feel transferring at 111 plus 3 means what? 114 hours vis-a-vis 120 hours. Does 6 hours changes anything? Well, these are the matter of speculation. What I see is when we have a report of 111, why should we think that 120 hours report should be correct? I don't think so. Because going by that, what I imply by that is window of implantation for HRT is usually considered to remain open for close to 6 hours. So if I go for 111, if I add 6, how much it becomes? 117. So I would certainly not look at 111 as same as 120. I would not look at it that way.
Sachin bhai. Dr. Sachin, I'm not able to unmute you. Yeah. Yes, Sachin. Are, where is gone? Sachin, Dr. Sachin.
Yes, sir.
Yes,
Hi,
yes.
Chinmay. Hello, sir. Excellent
Hello.
presentation, Chinmay.
Thank you, Sachin bhai.
Chinmay, a couple of points which we had discussed long before this presentation. I think I don't know whether I missed out or not. One very important thing before doing an ERA is you have to have a good embryo. That is what you had told me.
Yes.
If you don't have a good embryo, please don't waste the money on ERA.
Yes, sir. Absolutely.
So that is one mandatory thing, that the embryo, ideally blastocyst, has to be there. Only then we consider ERA and wasting money.
Yes, absolutely.
So
Unless
that is,
we feel that even in ERA report, if you look at them very clearly, they have mentioned that day 3 embryo transfer, if you have to do, you have to minus around 48 hours from the given window of which is ideally suited for blastocyst. You subtract 48 hours and you transfer day 3. I have had cases where, those cases things have worked. But I personally feel that why should we compromise on embryo and then talk about ERA? We should have a good blastocyst and only then we should talk about ERA.
right. So that one thing we need to
I'll
keep
give
in
you a
mind.
very clear example for that, Sachin bhai.
Yeah.
I have a patient with history of 5 miscarriages. The patient underwent PGS. We had total 6 embryos. Out of that, only 2 got selected. Okay. So here the classical case where there was even embryo problem. Now, after getting that, I suggested patient that please let me check your endometrial receptivity as well. She allowed us. You will be surprised to see that even her endometrium was also displaced. Now,
Correct.
not only the euploid embryo was required, a displaced implantation window was also there. So the both husband and wife both were fighting. So yes, your question is absolutely, your views are absolutely correct, that to do ERA, we must have a good embryo. A good ERA doesn't substitute for a bad embryo. It is not.
Right. So that is one thing. And secondly, this might not be very feasible
Okay, that was all.
for doing batch.
Yeah.
Sir, one more comment. this would not be very feasible
Yes,
for
yes,
people who
please.
are doing batch.
Yes. So now, like I said,
Sachin, you're not
bhai-
audible here.
Hello. Hey, can you hear me, sir?
Sachin, you're not audible.
Hello. Oh, sir, hear me? Hello.
Yes, Sachin bhai, we can hear you.
Sachin,
So another
Sachin, you're
point.
not audible. He was not audible.
Okay.
Sorry, can you hear me now?
Hello. Yes,
Hello. Am I audible now?
yes. Now audible. Yes.
Yeah. Another thing is this might not be very feasible for people who are doing batch IVF.
Yeah. Yes. So Sachin bhai, like I said,
So how do you, so Chinmay, so my question is, a lot of people in this group are doing batch IVF, though I am not.
Okay.
How do you optimize ERA for a person who would be doing batch IVF?
Yes. So what I will suggest to all of them is, if you are doing batch IVF and if you are so good at orchestrating simultaneous stimulation, all you have to do is just round all of them up, whosoever prospective candidates you feel for ERA, okay? Round all of them up, put them on OCPs, time their menstruation, do their ERAs at once so that it will be economical. And only after that successive cycle, immediately you begin the stimulation. It is very much possible.
Perfect. Thank you so much. Thank you, sir. See you tomorrow for the FET protocols.
Yes, yes. 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 Dr. Jariwala. Dr. Jariwala, can you hear me? Jariwala sir? Dr. Mahesh Jariwala? Are you there? I'm muting him again. Okay.
Yes, sir.
Who is there? Dr. Kunika Chechi. Dr. Kunika.
Hello. Hello.
Yes, yes.
Sir, I just want to know
Speak
how.
little loudly.
Hello.
Yes.
I just
Yes,
want to
yes.
know how frequently we should assess estrogen and progesterone for this era.
Yeah. So you do one thing. First of all, on day 2 of your, at the time of adding estrogen for the beginning of ERA cycle, first of all, you do ultrasound and you first confirm the ovarian quiescence. If you see any developing follicle and all that, then it is better not to fiddle with it. Okay. Since you are doing on a HRT protocol. Number 2, if whenever you ensure ovarian quiescence, you begin the endometrial preparation with the help of estrogen, ideally you have a very close monitoring of endometrium and call patient on day 7, day 8. Check their endometrium. If you start seeing a good triple line endometrium, then
Yes.
preferably next day you send your values of estrogen and progesterone. Let us say you get a value of estrogen of 120 and your progesterone is 0.01. Means what? You can still stretch it for some time. You can go for another 2 days, 3 days. Now, why is it important? For a good progesterogenic endometrium, you require first good estrogenic endometrium.
Okay.
What happens is, if we become greedy by seeing triple line endometrium just because protocol says big 6.5 add progesterone, no, it should not be done like that. When you see a good estrogenic endometrium and then when you add progesterone, you will see a beautiful secretory pattern of endometrium. If you are early in that, what you typically see is you don't get a good endometrial thickness at the time of obtaining biopsy. And then even if your endometrium is molecular level receptive, that endometrium is not strong enough, I would say, to sustain pregnancy in the consequent cycle. So your endometrial receptivity array test should act as a dress rehearsal for that larger play which you are going to conduct next month. So you have to make endometrium just like you make endometrium for transferring embryos. Only difference is, rather than transferring embryos, you will take the endometrial biopsy.
Right.
That's it.
Okay. Thank you, sir.
Yes.
Okay. So in continuation to this, I would like to ask
Yes,
that
sir.
why the cutoff of progesterone is kept at 1? Because early, what you do not want is premature luteinization, And
Yes.
as per the standard, you label premature luteinization only and only when the serum progesterone is approximately more than 1.5. That is approaching near 2.
Yes, sir.
To be safer side, 2. So why such low cutoff is kept? Because luteinization, until the luteinization is not started, progesterone is not going to be there in the endometrium.
Yes, sir. So
That was my query.
yes, sir. So the explanation for that is what happens whether endogenous or exogenous progesterone. What they have seen as beyond the cutoff 1, beyond the cutoff of 1 in the progesterone, whether it is endogenous or exogenous progesterone, what happens is it starts exerting on the autocrine and paracrine factors of the endometrium. And when that happens, your transcriptomic signatures, they start changing. What I mean by that is a natural endometrium may be receptive for say 12 hours, 8 hours, more than that perhaps. But when we are doing with HRT, we have perhaps a shorter, briefer window than that. And if we allow the progesterone rise beyond that level, what has come into my reading is basically it tends to shift the transcriptomic signatures. What we want is we want to pick up that transcriptomic signature perfectly. So going by that, they have in their analysis they have kept a cutoff of 1.
Okay. In your earlier slide, you say you have shown that SCG plus progesterone. You add progesterone even after giving SCG trigger.
Yes.
So you said you add progesterone from 2 days after the SCG. You said.
Yes, sir. So here
how you add after SCG, how you add progesterone after SCG trigger?
Yes. So ideally in our discussion, I mean, when we think of it, follicle ruptures, ideally from 36 hours, the time starts, right? Now what happens is it is written HCG plus 2 simply because if today my follicle is 18 mm, tonight I will give trigger, right? So today is HCG day 1, today is HCG 0, tomorrow is HCG 1, day after tomorrow morning only patient will come to me. Yeah. So and at that time I will start adding progesterone. Now here the most important key is, sir, that when we give trigger at the night time, if we give trigger, then we have to be very careful. What happens is if we give a nighttime trigger, let us say we give a trigger of 12 o'clock in the night, and we call the patient, the next day, and we add progesterone in the morning. Okay. What essentially happens is we end up giving less progesterone than what is required. Means what happens is if at night we give trigger, next day we start calculating, and on the day of biopsy, if we call a patient and take biopsy very early, then we tend to have borderline progesterone exposure. To avoid that, it is advisable that if you are going to, whenever you are going to give progesterone, calculate from 0 hour. So what I do is we write on paper at what time the first dose was administered, and just like clock, we calculate the number of hours of progesterone which is given by us. Obviously, even that applies to natural cycle as well, wherein we have to actually presume that endogenous progesterone rise has also started happening. But even in those cases, what we do is we monitor on paper how much exogenous progesterone hours are given. And to avoid mismatch in that, we try to make sure that at least 120 hours of exogenous progesterone administration is done. Only after that, we tend to wait 3 hours more than that, and we give only then we do biopsy. So that either way, progesterone is exposed, endometrium is exposed to progesterone for at least 120 to 126 hours. Going above 120 hours has got no problem. If your endometrium is 120 hour receptive, and if you end up giving progesterone 127, your report is not going to change. Okay. But if we end up giving less progesterone, then there is a problem.
Now there are two apprehensions in this, what you suggested. One is, what about the endogenous progesterone which is secreted following your SCG trigger? You have not accounted that.
Yes, we have not accounted that, and simply
Because what happens after SCG trigger, there is an
Yes.
exponential, rise in the progesterone after SCG trigger, and the peak progesterone is after 48 hours, and
Yes,
then start declining from fourth day. So we have to take this in account. My another question was, why to give SCG trigger once the follicle has reached at maturity and
Yes.
endometrium has grown sufficiently? Rather than giving SCG trigger, why not to start straight with progesterone? Because you really do not want ovulation.
Brilliant, sir. These are the two things which I have also
Yeah.
repeatedly, asked Carlos. We had even
Yeah.
sent email to their study group, and
Mm.
the only explanation what they have said is monitoring the natural cycle. In terms of hormone evaluation, even if you manage to add progesterone perfectly or you don't give, let us say, the problem is replicating the same hormonal profile even in successive month is not so easy. We may not have the rupture exactly at that time, or we may not. I mean, the replication of cycle per se is very challenging. So personally now, since there was a presentation, I mentioned two protocols of natural cycle and FET, but HRT. But now they clearly tell you that please don't go with natural cycle. It is better to stick to HRT, because cycle to cycle variation with HRT chances are far less than the chances which may happen with natural cycle.
So I gave a very interesting paper which says just against this. What
Okay.
it's a case history. If you want, I can send you screenshot. What
Yes, sir.
they did in recurrent implantation failure, and the HRT, the error report was non-receptive endometrium.
Yes, sir.
So they neglected error test. And what they did, they did a transfer in the natural cycle,
Okay,
absolutely
sir.
natural cycle, in which HCG was not given. Only
Okay.
progesterone was started, and they exactly after 120 hours they transferred them a blastocyst, and she got pregnancy.
So I will share
So
with
just,
you the
this was a
same.
reported case
Yes, sir.
history.
Sir,
Only single case.
I have exactly done that. Now what I will share with you is a very interesting case of a thin endometrium, wherein I had sent ERA. The ERA report came of 135 hours, okay, of receptive endometrium. Patient had undergone classical FET protocols before as well, of 120. So I had followed the ERA and I had transferred the embryos, and cycle failed. Okay. From the same subset of embryo, I told the patient that this is my last go. I took the patient on natural cycle, modified natural, I would say. Okay. And what we did was, we actually by clock, we calculated from trigger point exactly 135 hours of progesterone exposure. Okay, sir. And we transferred the embryos on a window which was given based upon HRT, but basically it was given based upon the progesterone exposure. And we transferred the embryos in the similar way, and we have a successful pregnancy ongoing with that. I did not show it because the patient has not delivered, but I have a similar case report, sir.
So I just wanted to share that this thing. Photo. No, I am to share screen. Screen. Okay, start now. And where is the camera? Okay, this was the study.
Okay, I see that, sir.
I have taken photograph.
Yes.
So just it was just an interesting study I came across.
So the point is, anyway, sir, it's something wherein this is ongoing mystery, but definitely we see that.
No, I totally agree. I totally agree with you.
That I have seen that even after ERA cycles do fail. Okay, but the point is, half of the cycle get rescued, which were not the case before. So
now I'm telling you something which is again interesting question. Okay, suppose you are doing HRT, and suppose some follicle pop up after 8 days of the estradiol, then how do you manage that? How do you consider that cycle? Carry forward this cycle? Do you cancel not taking biopsy, or how exactly will you do?
Sir, had I been Koradia, sir, I would have dared to do that. I personally do not have guts. When I see that and when I ERA report, I personally don't have that much guts. I simply tell the patient that I have to, cancel this month because follicle is developing. Because I feel that becomes too risky to, have a look at follicle, have a look at estrogen. Personally, I'm telling you very frankly that I cancel the cycle.
Okay. And you rightly said that progesterone should be given 8 hourly. The commonest mistake everybody does is they give 12 hourly. I am strongly supporting your view of inserting progesterone 8 hourly.
Yes, sir. And that too, the abroad so-called, white protocol mentioned 200 mg BD. That is for even waste. We have to give 400 3 times a day. I give, because what happens is, no, sir, the another advantage of ERA is we can actually save up on a lot of injections, because in the same protocol, I had plenty of series of women where what I did was at the time of embryo transfer, I just gave them that same support. Okay. In one group, in another group, I gave injection, and in another group, I gave them vaginal plus oral Dufastron. That much I gave. Okay. And all across, I did not find any difference.
Okay.
Because the initial which was given vaginally, that dose itself was sufficient. But before that, what used to happen, I used to get receptive report initially, and then when I used to measure the progesterone levels used to be low, and then I used to have problems in implantation as well. So when I myself corrected this on my own, I found a lot of improvement in implantation.
Okay. Another important, very interesting question. Because after Lotus 2 trial, everybody is jumping or tempted to use Dufastron as a luteal support. So is there any paper published or any studies done absolutely as a Dufastron as a luteal support and mimicking same after doing the ERA?
Well, sir, Dufastron 2 BD, that's what, 1 TDS or 2 BD, the recommendation of only oral support. I would say that as of now, personally, I have never tried that. Whatever reading I have done for this, I did not come across this, but I'm sure it must be there somewhere, but I do not have knowledge about it.
No study has been done so far?
No, sir. As far as I have checked, I did not find.
Even I couldn't find. That's true.
Sir. Yes,
okay.
Sir.
Another interesting thing. You said that you will not mind continuing estradiol while before taking the ERA sample.
Yes, sir.
So suppose even after 15 days, 16 days, 18 days, till how long you would not bother about the endometrial prolongation of the estradiol exposure to the endometrium?
Many a times I have done ERA test on day 22, day 23 on HRT protocols. I was not happy with the endometrium. I kept on going with HRT cycle till day 15, 16, 17. Till the time I was not happy, and only severe for Asherman syndrome cases wherein I had a patient with just 5 mm endometrium. I kept on giving her estrogen till day 17. Only after that I added progesterone and I obtained biopsy, and this patient has delivered with me after ERA.
Okay. Because even I was also thinking same till I came across the study where they have concluded that if the estradiol exposure is more than 18 days, that's the upper limit. After that, the results start decreasing marginally, but then not very significantly.
But I agree, sir. But what I felt was, in humans, the best implantation period is day 19 to day 22. Am I right, sir?
Agreed.
So what I tried was in HRT, I was trying to replicate that, because on one side I was not having good endometrium. So we took the endometrium as close to day 16, day 17 as possible. And then we added progesterone. And we did find that there was definitely, improvement in that. But I am of opinion that, the first cycle, when we are doing ERA, at that time, we have to be convinced about the estrogenic exposure of endometrium, because what happens is half-heartedly, if we add progesterone in that, without being clear about how the endometrium looks and does it really look estrogenically rich, what happens is then you have a report and then we are in soup, because at the time of transfer, somehow our examination style is different. At that time, we suddenly don't start liking that endometrium, which we started liking at the time of ERA, because now we are going to transfer and then we don't like that endometrium. So that is why I mentioned that when we are doing ERA, we must do ERA in such a way that thinking as if we are going to transfer embryos in that cycle rather than thinking that we are going to take biopsy in that cycle.
Okay, suppose in the cycle, biopsy cycle, you are given estradiol for approximately 12 days.
Okay,
Now,
sir.
in again, after you get the ERA testing done, and next time when you're during the transfer cycle, suppose endometrium is not forming like before,
Yes.
after 12 days of estradiol, then what we will do?
Yes, sir. So many a times we have seen that. Now, as we start applying ERA to multiple failed IVF cycles, thin endometrium, so on and so forth, where we start expecting these problems, definitely we have seen that even the replication becomes very difficult. Now, when I said the replication has to be compulsory, what I meant was if we get all correct parameters in the following cycle, then we must not be lazy enough to prolong it by a day or two. But I have seen that cases where we did not like the endometrium, we have moved even 3, 4, 5 days beyond. For those cases, not for all. For those cases where principally the endometrium was not good and we changed those days, we have got pregnancy. But what I've had problems with was when I liked the endometrium and just because it was falling on a certain day, which I did not want, when I tried to change it on a larger scale, I did face problem. That's what I meant was, if you have a good endometrium, please don't postpone it by a day or two. Go ahead with as the protocol is, there. But if the endometrium you are not liking, as sir, I have learned from you as well, a good estrogenic endometrium is the builder of the building. So we cannot neglect that.
Yes.
So definitely.
So I'm coming to Dr. Mahesh Jariwala. Again, he is, I think, online. Dr. Jariwala, earlier I tried to unmute you, but I couldn't.
Hello.
Can you do something?
Can you hear me?
Yes, now we can hear you.
Sir, honored
again,
hear from you, sir.
Okay. Very nice and intelligent presentation on ERA. Thank you very much, Chinmay.
Thank you, sir. Thank you.
I am having two questions. One, that is, what is your cutoff value of progesterone on which day?
Okay, sir. So usually, sir, I follow a cutoff of both estrogen and progesterone. Unless and until my estrogen is not more than 150, I will not add progesterone. At the same time, if usually most often than not, what I found was if the estrogen is added exactly on day 2, usually these progesterone values are essentially very, very low. They are hardly 0.2, 0.3. Very rarely we see that rise of progesterone. But even in those cases, I personally keep a cutoff of 0.8, 0.9. I don't go beyond that. And for the day you are asking, usually for 12th day, till 12th day, I can risk with those rising progesterone titers of, let us say, if on a day 9, I get a good estrogen, but I don't, I get I'm getting a poor estrogen values, but my progesterone, values are rising. Very rarely I have seen that. Wherein on day 12, if my progesterone are, inching dangerously forward and still I don't like endometrium and still I don't like estrogen, those are the cases where I have postponed it for the next month, and then somehow those phenomena have never repeated. But coming back to your question, usually we find that if we add progesterone on day 9, and even if we don't monitor, simply because I have so much data, that's why I can say confidently that if we add progesterone on day 9, there is no chance of progesterone rise, even if we don't do it primarily. Let us say somebody is doing it at a very remote setup where they don't have even progesterone reports available, but they want to do ERA. I feel that if they see a beautiful endometrium on day 8, day 9, they can safely move beyond from day 9, because multiple reports also say that 8 days of estrogen exposure is minimum. So let us say we are seeing 9. So if on 9th day we see good endometrium, we see this thing, then you generally do not come across these progesterone rises. They mention it that it must not be more than 1, but I personally would say it happens in less than 5% cases where the progesterone jumps suddenly out of sleep and such things happen. So even if the monitoring is not done, but the endometrium lining is good and estrogen administration is done perfectly on day 8, day 9, I don't see any worry.
Okay. My second question is, have you ever compared the windows of implantation, means group of the patients who are having a windows of WOI, means windows of implantation, and its sonography findings, whether they are suppose the report is shows that these particular days are having a good receptivity, right? And on that day you do the sonography, and do you find any difference in
Yes,
the
sir.
sonography
Yes, sir.
pictures of that patients?
Yes, sir. So there are two aspects which I would like to talk about. First, the day when I take the biopsy. Okay. And then I will talk about the look, what I see on the sonography when I am going to add progesterone as well. Two aspects. So day 0 of the progesterone and day 5 of the progesterone. I'll talk about two. First, I'll talk about day 5 when I call the patient for biopsy. Many times out of interest, I have monitored to take their sonography pictures on the day. When I see that a nice, endometrium, I mean, I would see a secretory pattern, yet you see some sort of homogeneity, some sort of, that typical endometrium. When we see, those endometriums are usually receptive. But when we see a completely homogeneous, thick, white endometrium, bright white endometrium, usually we know that this endometrium is going towards post-receptive. Similarly, on the day of administration of biopsy, when we see just like as if endometrial progesterone exposure did not happen, we start seeing a triple line endometrium after adding 5 days of progesterone. Those days also we have seen these problems happening. So you are right, absolutely, that yes, we have seen these three occurrences happening, which actually correlate with the sonography appearance of the endometrium.
Thank you, Chinmay. So nice presentation. Thanks a lot.
Thank you, sir.
Now coming to Dr. Nilesh Shah.
Yeah.
Dr.
It
Nilesh,
was an
please.
awesome present. Yeah, it was an awesome presentation, Chinmay.
Thank you, thank you.
Because it is a very recent subject and you have given a very good insight into it. I am having two questions. In all those patients where you want the ERA to be done, and when you see that the blastocysts are not okay, not good, not bad, would you subject all those patients for PGS?
Yeah. Now about that, the first and most important rule with me at my center is I happen to have time lapse with me.
Okay.
So what happens is when I'm seeing those blastocysts not doing good, I tend to first analyze their till day 5, how their time lapse monitoring has happened. So that gives me insight about those reverse privileges and all those things. Secondly, I would say that a definition of good blastocyst can be defined only after thawing. So at the time of freezing, if the embryologist is relatively happy, he is not super happy, but he is okay, and the patient is having history of previous multiple failures, then those are the cases where I would rather think about both factors, and yes, PGS would come into play. But if I have a very limited number of embryos, less than 3 blastocysts or less than 3 blastocysts, I would certainly not go ahead with PGS. I would try my luck with those 1 or 2 embryos, with first correcting the endometrial factor, because usually those ladies which you are mentioning tend to have previous failed cycles as well, and most of the time onus is put on blastocyst being good or bad. Now we all have seen bad blastocysts giving pregnancy, but in such cases, I think if the case is getting towards PGS, or cases you are looking at the embryo that much seriously, then I feel the first factor should be counted is ERA, because it is far easier to do ERA than doing PGS in terms of anything you take. And nowadays you have a packages. So if your patient is classical where you have 7-8 blastocysts and you have a previous failed multiple cycles severe PCO patient, and you have then you get a package where you do ERA as well as you do PGS and then transfer. It is a fantastic way of doing. But I would still be very cautious about PGS if and only if I have something wherein I'm putting patient money also, and if at the end of it I don't get good embryo, then there is no point in doing ERA as well. Similarly, I wouldn't suspect everything about embryo itself without checking the endometrium. So it goes both ways.
Because recently I had one patient with
Nilesh bhai. Nilesh bhai. I would like to add something. The endometrium and embryo both compensates marginally for each other. They let go marginally for each other. So if the blastocyst is ploidy, it is not aneuploidy. Ploidy blastocyst, even though morphokinetics is not good, morphologically it is not a grade 1. Still, if the endometrium, if it is put in the correct window of implantation, I think endometrium will accept it. The same thing is true with the opposite. If the endometrium is little bit thin or the vascularity is less, but if you put a very good blastocyst, you can get the result. Implantation can occur. So marginally, both let go for each other marginally, not to a greater extent. Am I right, Dr. Chinmay?
Yes, sir. Absolutely. See, the point is, now this is something which really blew my mind in last tertiary, wherein, you know, now please listen to this line carefully. A good embryo has the ability to correct a bad endometrium. Now, I thought that was a awesome line because that it is like a good parent knows how to correct its child. You know, even if that child is little bit naughty, it can still manage to get it, you know, online. Because the embryo can exert so many autocrine and paracrine factors, it tends to have even the influence on proliferation. Since if you look at it in your clinical practice, the moment you have a patient of positive IVF cycle, if you call them up after embryo transfer 6-7 days, suddenly boom, you have a great endometrium. Now please tell me, at the time of embryo transfer, after administering 5 days of progesterone, if you had a decent endometrium at the time of transfer, where you don't change any degree of progesterone support after transfer as well, suddenly what happens that your endometrium just picks up the pace. Clearly, the embryo also has the ability to exert influence on endometrium. Similarly, the endometrium also has the ability to heal the embryo. What the problem with PGS or the problem with blastocyst transfer is, the newer theories are wherein the scientists say that the fertility specialists are arrogant enough to think that a blastocyst only can give a live birth rate, improved live birth rate, wherein they do not understand that perhaps a day 3 marginally bad embryo, perhaps nature has the ability to compensate for it and take it to the good blastocyst, which our labs cannot. Now that is very controversial, but you know, it kind of, I would say it is coherent with what you are mentioning. So I thought I'll just
explain. Then it is self-corrective mechanisms are always there with the embryo, inherent with the embryo. Self-correction, self-corrective. Yeah.
Yes.
Rajesh bhai, recently I had a patient with pelvic tuberculosis and we did the pickup. We got probably 8 to 9 embryos, and we transferred the 2 out of it, and we get the negative result in the next cycle. So what we thought was, ERA should be done, and then we should transfer the second time. But before that, we did the PGS, and in all, unfortunately, all the 7 blastocysts were aneuploidy. Correct. So
yes, it can happen.
Then there is no need. That was a very bad scenario for us.
I agree.
That now we can't proceed with the ERA, and we have to tell the lady that unfortunately every blastocyst is bad. Those are looking good embryologically, microscopically, but PGS results were all negative in all the cases.
Yes. So what I would like to share with you, sir, here on the similar lines. Now imagine you are having a pelvic tuberculosis patient where you are having a oocyte donor. Okay. You are having embryos, and what are the chances wherein you will think that your embryos were bad? Only because. So the point is, what I'm saying is, I have had a series where I had done PGS even for patients who went for oocyte donor cycles, and I saw that a perfectly fertile woman also produces aneuploid embryos.
Yeah.
Okay. Correct. So that thing is there. You know, what I'm saying is, in this typical Rassi case
and very important thing, again I'm telling, Nilesh bhai.
Yeah.
If you have to rely technically to take error test biopsy for error testing is not challenging. It's very easy. Whereas to do a PGS embryo biopsy is technically itself destroys the embryo, disturbs the embryo, and your result. There are papers which says that by actually doing PGT, you are harming, you are reducing the number of the embryos available to you. So if you have to rely reliably, in a reliable way, then probably you should rely more on ERA rather than PGT. If morphokinetically the blastocysts are looking okay.
Okay. And sir, the second question is, there are certain gray zone in my brain during the HRT cycle that you said. Now, when we give the estrogen for around 5 to 6 milligram per day, and probably on the 8th or the 9th day, we see the endometrium is more than 6.5 mm. And you said that the progesterone should be less than 1.2 and the estrogen should be more than 150, correct?
Less than 1, sir. Progesterone should be less than 0.9.
Progesterone should be less than 9 and the estrogen should be cut off must be more than 150.
Yes.
Correct? Yeah.
Yes.
Then we give the HCG, correct?
You are saying natural cycle. Okay, correct.
No, I'm talking about the HRT cycle for ERA.
Then why would you give HCG?
Why HCG?
Okay.
Why HCG?
HCG is not needed. Then we add the progesterone, correct?
Okay.
And the progesterone should be given in the dose that you prescribe, 400 milligram TDS.
Yes.
Okay, and that we give 400 milligram TDS for 5 days, correct?
20 hours, sir. What I'm saying is, for endometrial receptivity assay, we have to be slaves. We have to be dedicated slaves to the clock. I would never say 5. I always keep on saying 120 hours. So you just make sure the first dose is mentioned on paper. Your doctors, whoever is writing on paper, it must be mentioned the time, and it has to be absolutely determined that 120 hours of exposure is done. Not only that, you go over and above at least 3 hours, because when you administer progesterone, you cannot possibly expect that progesterone absorption starts from that second. So even if a woman administers a vaginal capsule, from it to base these and to vaginal mucosa to uptake, I don't think Korodia sir can tell us better, but I don't think the situation will immediately start. It will take some time. So I need to calculate in terms of blood progesterone, and I feel that it requires at least 3 hours over and above that. And that is what Carlos also recommended when I spoke to him personally.
Okay. Exactly. I'm coming. You opened another Pandora box. So, which is the quickest method? I mean, quickest reach of progesterone which enters into the circulation. That is the vaginal progesterone. That is the quickest to enter in the circulation. Not even intramuscular progesterone. Not even intramuscular progesterone. So, whenever you want to pinpoint especially for ERA testing, you need exactly in hours. Then probably the moment insert vaginal capsule, you can add 1 or 2 hours after that, and that should be your counting hours.
Hence, sir, what I said was I usually go 3 hours above that. So that puts us in really safe.
That is okay. 1 to 2 hours, 3 hours.
So that means that after 123 hours, we can take the biopsy.
Yeah.
Okay, perfect. Okay, sir. Okay, thank you. Okay.
Thank you.
Dr. Sachin wanted to say something. Sachin, bhai?
Yes, sir.
Bolo.
Sir, just wanted to add one thing about this 122 hours confusion. I have experience of only one ERA. That also was a natural cycle. So I had to do a lot of reading and speak to people, because even the iGenomics people were not very sure about how to go about a natural cycle. Because here I had a patient who was 2 IVF failures. I had put the papers on the verdict group. So now simplest thing is to know what 120 hours is. You ask the patient to start progesterone at 9 or 10 a.m. in the morning on Monday. And on Friday, same time, 10 o'clock, you do the ERA testing.
Exactly.
So that is the easiest way to remember, because this 120 hours thing becomes really confusing for a lot of people. It was a challenge for me also and my patient also. So for regarding that patient, I went back and forth with Chinmay a lot of times, because he also said that regarding doing with natural cycle, there's a lot of challenge. But here the problem was that with HRT cycle, the woman's lining would just not increase, while it would only increase with natural cycle. So that is one thing. And second, yes, sir.
I would like to share the one more picture, which is for exactly natural cycle ET. That's good,
Yes.
I think. So I'm sharing with that. Okay, just it will take 1 minute more. Where is camera? Okay. So this is a beautiful interaction with the levels
Beautiful.
about the natural cycle. Yeah.
Okay. Fine. So that is one thing. And
Okay.
second thing in
Just a minute.
response to,
Yeah.
yes, sir. Oh, sorry.
Just a minute. Not able to coming out. Yes, you can go ahead.
Yeah, and second was in response to Nilesh Bhai's query regarding the PGS. Now I have read about it, spoken to a lot of people about PGS. What they are saying, the way Chinmay mentioned that the embryo corrects a faulty endometrium. Similarly, after implantation, the endometrium and the uterine factors are also known to correct the embryo. So if we are doing PGS and there is a minor translocation here and there, we might not be wanting to do a transfer of that embryo, but actually that might not really have any clinical significance. So we should be really strongly justified about which patients we want to do a PGS before applying it to all.
Yes, absolutely. So Sachin bhai, where what happens is when these previously failed IVF cycle patients come to us, usually the indications which we mentioned, these are the indications of ERA which actually point towards endometrial factor more than the embryo factor. So
Right.
in such cases, rather than leaning towards PGS, it is better to lean towards endometrium, simply because if patient comes to you this month,
Yes.
in a 20th day of menstrual cycle, and you counsel her, boom, after 7 days, you can immediately begin her ERA. Before she is finishing 2 consultations with you, you already know her progesterone, endometrial implantation window. Now, after that, when you do IVF cycle and when you check embryos and all that, and if there is evidence which suggests that probably embryos are getting abnormal or something like that, then you have 2 options: either you do PGS or you don't. Let us say you
Correct.
do PGS and you have abnormal embryo, then
Correct.
also fact remains that her endometrium requires a different scrutiny. Now if her all embryos are abnormal and if you give her oocyte donation or embryo donation, whatever, even those oocyte donor embryos or embryo donor embryos are going to require a receptive endometrium. Now,
Correct.
woman who is frustrated with 3 failed IVF cycle should at least have some safe, thing to lean upon. So the moment patient comes, if we do get away done with ERA, anyways to prepare patient for IVF cycle requires a month. So in that time, if we finish up with ERA, we have one arm completely secure, that is endometrial window. And then we move on towards stimulation, and in that, if required, we may or may not do PGS. But even if we do PGS, and even if we get a euploid completely normal embryo, or we get a mosaic embryo or an abnormal embryo, all those 3 embryos ultimately are at the mercy of endometrium.
Correct. So what I was saying is, as I had spoken to Dr. Jatin Shah some time back, that we would be very selective about in which patients to do PGS. Only if there is history of previous malformations in the children or an elderly couple. These are probably the only patients that we would be wanting to subject to PGS.
Absolutely.
Exactly.
Yeah. Thank you, sir. You can mute me, sir. Thank you so much.
Thank you.
Yeah. Dr. Chinmay, very interesting question I'm asking.
Yes, sir.
Suppose we have stimulated the patient and we are planning for error testing, and now we are looking at the embryo morphokinetically. There are a few embryos which are rapidly forming blastocyst. So before before 112 hours, the
Yes, sir.
blastocyst is well formed, and some of the blastocyst has formed around 120 hours or 118 hours.
Yes.
Now, for all practical purpose, will you consider them same, or will you differ while counting the embryo endometrial age?
No, I will count them different, sir, for two reasons. Whatever data I have, in which I have seen maximum pregnancies happening, and for right reasons. So, for the blastocysts, which were between 118 to 122 hours. Okay. Now, these rapidly forming blastocysts.
But this is for fresh transfer, huh? Not for frozen transfer. This paper was for fresh transfer.
Okay, for fresh transfer. So, yes, sir. This is again a valid question where why the embryos are growing so rapidly or vis-a-vis certain embryos which are growing at a normal pace. Now, here what I've seen, sir, is these rapidly growing blastocysts, their energy requirement. Again, we come back to mitochondria and ATP. Their energy requirement, I would say, their energy requirement environment sometimes doesn't match with the fresh endometrium. That's what I've seen, probably for two reasons. The superovulation itself displaces the window, but somehow I have found that these embryos also, if they are frozen and then they are transferred, they have relatively better chance. That's what I have seen. I may be wrong, but this is my...
Exactly. I'm telling you exactly what is what. See, if as far as rapidly growing blastocyst versus delayed formation of the blastocyst, if you want to transfer always never transfer delayed forming blastocyst. That is to be frozen, not to be transferred. Because if you transfer, there is a lot of asynchrony between endometrium embryo. Endometrium has moved ahead than blastocyst. So there is no point in transferring fresh. There is no second opinion about it. It has to be frozen. That is one thing. Second interesting conclusion is there is no significant difference between clinical pregnancy implantation rate between day 5 frozen thawed blastocyst versus day 6 frozen thawed blastocyst. After once you provided you have taken care, you have transfer after 5 days. Similar, considering them as a 120 hours only. So what they have advocated, even if you have frozen the blastocyst, this fact very few people know, because this is very, very in depth. You have to read this paper. So what they did, even if they vitrified the blastocyst on day 6, they transfer after 150 progesterone plus 5 only, similar standard way, progesterone plus 5, they transfer day 5 blastocyst and day 6 blastocyst in obviously frozen transfer, and the success rate was same. So so my conclusion is, as far as counting the age of the embryo, we have to go by morphokinetics, not exactly by hours. So if the properly formed blastocyst, we should consider it should match with the progesterone plus 5 only endometrial age, not more than that. So here, in such scenario,
it is absolutely right. And just to elaborate with that, what I'll tell you is, when I've shown you those windows, wherein the patients had implantation window of 96 hours and the another of 168 hours. In both cases, I was having that puzzle that how am I going to now match the embryo? Because the embryo was around 119, 122 hours. By the time I transferred, that embryo was perhaps 125 hours. And what you mentioned, probably that is the only explanation how it happens, because a 125-hour embryo getting implanted in a 95-hour window or a 160-hour window is not explainable by timing, but what you mentioned by morphokinetically only. That embryo has to be morphokinetically normal.
Yes, yes, yes.
Yes, sir. Absolutely brilliant observation, sir.
Yes. Now, Dr. Dev. Dr. Dev.
Good evening.
Dr. Dev. Good evening.
Good evening. Can you hear me?
Good evening.
Yes, yes, we can hear you.
Firstly, I'd like to really mention that this lecture has been an eye-opener and it's been totally exciting, especially the part of discussion on the discussions. I've got one comment and then 3 questions, actually. The first comment is with regards to the hormonal profile during the ERA test. I come from a center where we don't do routine blood tests because the takeover time to receive the results is usually after 24 hours. That's one. Number 2, I think a lecture by the talk by Christopher Blockhill the other day did mention that he has done a study which actually measures estradiol levels in frozen embryo transfer cycles. And I think it's published in the journal of, he did mention Frontier of Endocrinology this month. And he finds that measuring estradiol is actually not of a good value because of the limitations in tests and also the variation in the results. I've not gone through the paper, so I'm really not too sure exactly the details.
I totally.
That's one. Number
I
2.
agree. I agree.
Number 2, with regards to progesterone testing, I think surprisingly, the talk by Nicholas Polizos the other day also did mention that there is apparently a diurnal variation of progesterone, which I didn't know before, where he was talking about premature progesterone rise. And if you take a test at 11 a.m., 11 p.m., or 4 in the afternoon, there are different values. So, I mean, that led me to believe that I think doing blood tests may not be useful. I mean, I don't know. I mean, I don't know with regards to ERA test whether it's valuable or not. That's one. Coming to my questions, if we were to use a PIPEL sampler rather than the one that is being provided by the manufacturer of the ERA, can we still use our conventional PIPEL? The reason why I'm asking.
Yes, absolutely. You can use your conventional PIPELAs with even syringe, no problem. Whatever you want to use, no, because in India, right now, perhaps Igenomics is the only company which provides the PIPELA along with it. Rest of the companies, what PIPELA, the quality they provide, I personally am not happy with it. So I don't use those. So even the regular PIPELA is fine with the syringe. That's absolutely fine.
Okay. My second question, I'm quite happy that you shared your laboratory results, and I'm actually quite confused at the same time. Because by eyeballing the lab reports that you gave, I think the timing of progesterone that you have taken, I see that the timing is sometimes at 6 a.m., sometimes at 5 p.m., sometimes at late evening and night. Why I'm asking is because in my place, in my frozen embryo cycles, after estrogen priming for about 12 to 13 days, if I'm happy with the pattern of the endometrium and I'm happy with the thickness, I will start my progesterone at 11 p.m. The first dose at 11 p.m. on that day, and that I would take it as P0. Okay. P1 would be my next day, and I would start micronized vaginal progesterone 400 milligram BD at 11 a.m. and 11 p.m. And I would do my transfer at P+5 at 11 a.m. If I were to calculate the hours, I would get 108 hours. And I've been getting pregnancies with that quite regularly. That's one. But previously what I used to do was, this change was actually almost, I think, a year or two now. Previously, I was doing it at P+6, exact timings. At P+6, it would be 132 hours.
Okay.
Of course, in between, I don't get results. I mean, so I presume that it could be an embryo. It could be an embryo issue because I don't do routine PGTA because of the cost and so on. So my question is, with regards to this timing of 120 hours, is it really a bare minimum? Or I could have been lucky because you did mention that the sensitivity and the receptivity, I could be at one end. I also could be at the other end, and that's how I could have been lucky all this while. But I would just like to know if that 120 hours, based on your test that you have, that obviously it's not the case, but on a general case, on a general
so
population.
I would explain it to you. The point is, for obtaining ERA test, the amount of progesterone exposure what you require is 120 hours, right? Now, I have already mentioned that ideally I would go over and above 3 hours over that, so that goes to around 123 hours. Now, what I'll share with you is most of my reports tend to show me the receptivity profile of 124 plus or minus 3 hours, right? So that becomes. Am I audible now?
Yes, yes.
So most of my reports are somewhere lying between 124 to 125 hours. And in that, the addition is plus or minus 3 hours. So I would say that on one side, when you mention around 131 hours of exposure, even with ERA also receptivity, we are coming into that calculation only around 127 to 28. Now, I refuse to believe that 2 hour, 3 hour here and there would change. Rather, it explains why you are getting pregnancy, because you are in that spectrum. But what I feel is the cases where perhaps you are not getting pregnancy, if you subject them to ERA test, perhaps you may find a difference.
Is it correct to say that 120 hours is the sweet spot then? If I'm not doing
20 hours is a sweet spot to calculate the hours of bare minimum exposure to obtain ERA test. It is nowhere a sweet spot for embryo to get implanted, because even if we take test at 123 hours, those endometrium tend to show their implantation window somewhere around 130 to sometimes 135 hours as well. So the sweet spot is for, now if we have to standardize the procedure and if we have to take biopsy, the number of hours has to be common all across. Only then they can have algorithms. And for that reason, I feel the 120 hours standardization is done.
Okay. Thank you. The third question,
Hello.
I think, yeah, hello, can you hear me?
Yeah.
Dr. Dev, you said P plus 5 is 108 hours. It's how it is 108 hours. 11 o'clock to 11 o'clock is 120 hours.
11 p.m. to
P plus
11
5.
a.m. is the initial 12 hours. And
No,
then
11 a.m. you are starting then. No, 11. No, 11 a.m. you are starting.
Is at 11 p.m.
That means start AM. AM or PM?
The P plus 0 is at 11 p.m. Hello.
AM, okay. So,
my
okay, then it is okay.
First dose. Yep. Yes. Okay. My final question.
Yeah.
There's a lot of talk about routine PGTA with ERA. I think there's a test by the study by the EV group now. I think doing exactly that, testing PGTA versus plus ERA versus ERA alone. But on a clinical situation aside, if someone has done a PGTA and has done an ERA, but both results in a non-pregnant patient, in those kind of cases where both has failed.
Sorry, can you repeat? Because, hello,
yes.
Dr. Dev,
Yes.
Dr.
Yes.
Dev, can you repeat? Because
So,
the connectivity is not
I
good.
got this question. I will just repeat it for you.
Yeah, my question is, how do we explain to patients, or what do we do next to a patient where she has done PGTA, we have euploid embryos, we have done the ERA test, and we have deposited them at the right time, but yet the beta is come back as negative.
Yeah. So Dr. Dev, first we have to understand that endometrial receptivity analysis is classified, or it is rather being analyzed by various omics. Transcriptomic is just one arm of those omics. What you have to understand is proteomics, lipidomics, they are the things which are still work in progress. And if those metabolism arms, if there is a problem at the level of tissue metabolism, then even by having a good gene upregulation, if your prostaglandin factors or if your cytoskeleton monitoring genes, if they are not up to the mark, then that can happen, that can result into failure of implantation. That is why we need to move beyond transcriptomics, and we need to have perhaps a test which will be a perfect marriage of transcriptomics, secretomics, proteomics, and lipidomics. Only then we will have, and perhaps a day where we have a non-invasive PGT also equally sensitive, wherein with a minimal invasion, we will get perfect implantation information, receptivity information, as well as embryo information.
In your case series, do you happen to come across such patients? And if you do, and
Yes.
what would you do differently in the next cycle?
Yeah, so I have had 2 or 3 patients where I had perfectly normal euploid blastocyst. I had a receptivity window which was defined by ERA, and I've already mentioned, and in those cases, somehow things did not work. And I was of the opinion that now, okay, I have a euploid blastocyst, I have a progesterogenic endometrium window which I know. So what I did was I took assistance of nature. What I did was I started calculating
assistance of
nature, wherein I started replacing those HRT cycles with natural cycles, yet I kept the hours of, that is why I mentioned, I keep on calculating hours, and there it came handy to me, because even in those natural cycles, I started calculating roughly. Now I know I cannot be very specific about natural cycle progesterone release, but those were modified natural cycles, wherein I started calculating progesterone exposure in terms of hours right from, calculating from the timing of trigger. And what I ended up doing was, if my ERA report says that it is 135 hours of progesterone exposure is required, I calculated 135 hours technically for a modified natural cycle, and I have transferred embryos and I have seen success in those cases. So I'm not saying it is a correct way of doing, but I did see that as a rescue thing. But like I said, only transcriptomic signature is not sufficient. There are cases with me wherein, despite doing ERA, despite doing everything right, things have not worked. We have had cases where, despite doing everything with ERA, in some pregnancies, we have had miscarriages as well. So in those cases, I have to go back and see whether I was lying when I transferred the embryos. Was the selectivity and receptivity spectrum was so narrow that I ended up transferring on the extreme right rather than the middle sweet spot? That may be possible. But now, all those are matter of speculation, and more than that, I don't have explanation for it.
Dr. Dev, I would suggest something, Dr. Dev, I would suggest, I would do something little out of box. You must have heard something called primer study, you must have read. So in primer study, in such cases where there is no explainable reason, everything is fine, still there is a recurrent implantation failure. So what they did, they used GCSF subcutaneously, plus they used PRP. And nowadays I keep reading a lot of things about using growth hormone for improvising the endometrial receptivity. So I would add those arms in my armamentarium, and when nothing is, everything is looking fine, then I will not hesitate to use growth hormone, GCSF plus PRP, and then let us hope for the best.
Got
Absolutely.
It.
Yeah.
Thank you.
Yeah, thank you. Are there any more questions, sir?
Okay. Yes, there are. Dr. Jayesbhai Patel, and before that, Dr. Pankaj Chaklas here. Dr. Pankaj Bhai,
yes, sir.
From Surat.
Yes. Good evening, sir. It was an excellent lecture by Dr. Chinmay till date regarding this new subject. I have 4 questions.
Absolutely. I totally agree.
Yeah. My first question is, once everything fine, recurrent implantation failure patient, I go for the ERA and endometrium excellent, and still I have failed. And what is your experience with it once ERA is failed? That is first question.
Okay.
That is what we just discussed, using other things.
Okay. Yeah. Next question.
Okay.
The patient with a thin endometrium. Endometrium is not increasing till in between 5 to 6 until I have done the ERA in the same patient. And so also the endometrium, I have tried everything, GCSA, PRP, everything I have done until endometrium is 5.5. I have done the ERA. And the report showing this time personalized embryo transfer this hour. I do this and still I again fail. What to do? And the embryo part is excellent regarding my morphokinetic pictures.
Okay.
What will you do next?
You have you are mentioning all of this, and all of us, we do come across this, but here you need to understand that there are 2 big spaces where there could be problem. Number one, a morphokinetically normal embryo need not be chromosomally normal. Number one. But
Yes.
since you have got such a thin endometrium, it would be, we should not be blaming embryo, but we should look at endometrium. And I agree that these are the scenarios where it happens. But what I'll tell you is, most often than not, like I said, and that is why I kept on saying it, that when you take the ERA test, you have to make endometrium in such a way as if you are going to do transfer. Now, what I want to tell you is, if your endometrium is 5 mm, it doesn't qualify for doing ERA test itself. It has to be more than 6.5. So the mindset with which you do ERA testing, no, it has to change. You have to look at ERA not as some savior or God. You have to look at ERA as a very good assisting tool. But for that, to use that, ultimately it is in your hand, and you have to make sure that when you do ERA, the endometrium has to be at its best, as maximum as it can. Okay. So what
Okay.
happens is, if you have an endometrium of 4.55, 5.5, just because you have told patient that you will do ERA, doesn't mean you have to commit for it. I have
Okay.
had patients where I have had to wait for 4 months till the time I have liked the endometrium, and then we have obtained ERA. Because implantation is, bound by the timing of endometrium. It is not bound by the timing of what is suitable for us. So we must be brave enough to cancel those cycles where you don't like the endometrium fit for taking ERA itself. So like I said,
Yes.
right now, what you are mentioning is the commonest scenario which I mentioned during presentation, because then you are really caught in a bad, space where the way with which you took the endometrial receptivity assay, that itself was not as best as you should have done. So probably you have to go back there and you have to correct that.
Okay.
So,
Another question, question 3. In
Pankaj
patient with,
bhai,
yes,
quickly,
yeah, yeah,
because we are running short now.
yeah,
Please.
yeah, quickly. Patient with severe adenomyosis, or maybe patient with severe endometriosis, grade 3 and 3. In this patient, we require down regulation by GnRH for 2 months or 3 months. And how do we proceed for ERA test and ERA once control, and how do we for the frozen cycle transfer? Because down regulation is disturbing your timing.
But what I'm saying is, whenever you are planning to do ERA followed by stimulation, no, you have to always, the ERA always has to precede the stimulation. When you are planning to do an ERA for a particular whatever cases you are mentioning, you have to make sure that first you will do ERA, you will finish that cycle quietly, and only then you begin your down regulation. Whatever months you want to take, you take it, because ERA result don't change with months. No, we have mentioned that in paper. Then you do your 2 months, 3 months down regulation. Then you do your stimulation. You obtain your blastocyst. Let patient have periods, and then you transfer as per ERA. It makes job so simple.
Okay, for ERA test, there is no down regulation is required in same patient.
No, ERA, there is no question of down regulation. You have to do ERA in a non-stimulated or a non-down regulated way. You cannot give, agonist or antagonist for that.
Okay. Another last question. Once I do ERA in a fresh OPU cycle, and then what is the ERA finding, and the second in the ERA test in the HRT cycle, like hormone preparation, what is the difference between the ERA hours?
Okay.
So what will be the best? Yeah.
First of all, ERA testing must not be done in fresh stimulated cycle. Okay.
Yes. Yes. Okay.
Second, what you just to make you understand how the stimulated cycle works, there are multiple reports, okay, where people have taken biopsy on the day of ovum pickup. Please listen to this carefully. People have taken endometrial biopsies on the day of ovum pickup, and on that day itself, endometrium was receptive. You are understanding? Forget about 5 days after that. On the day of ovum pickup, the endometrium was receptive. Such is the disturbed endometrial implantation window because of hyperstimulation. So you should never take ERA during stimulated cycle. It has to be in a non-stimulated cycle. Got it?
Now, okay, yeah. Okay, yeah, one, just a minute. Just a minute. Huh?
Yes, sir.
Okay. Dr. Jayesbhai Patel. Dr. Jayesbhai.
Yes, sir.
Yes, please.
Straight away going to question that can a sequential transfer, that is transfer on day 3 and day 5, replace ERA? Garibo ka Amitabh Bachchan.
That is an Indian jugaad.
Yeah.
So basically, if you look at it, what you will see is all those cases where before ERA the cycles failed, we changed the days ultimately out of frustration. So there God guided us and we were successful in some cycles we were not. The point is to do away with jugaad and to have some sort of standardization. We are talking about endometrial receptivity. But yes, if you are lucky enough that you are this thing, but what you need to understand here, there is a big problem that your day 3 embryos, you are assuming that they are receptive for a day 3 endometrium. Your day 5 embryos are receptive to day 5 endometrium. The problem is your day 5 embryo itself is not receptive to day 5 endometrium. It may be receptive to day 5, day 6 or day 7 of endometrium or day 4 of endometrium. So then where is the question of having day 3 embryo having the same space? Because the moment you have displacement of a blastocyst implantation, if you travel back in time, you are bound to have a displacement on day 3 embryo implantation time as well. So that is why sequential embryo transfer cannot replace ERA.
So what is something called COFENAC? COFENAS, C-O-F-E-N-A-C. COFENAS is a terminology, correct terminology to transfer same time different stage embryo, morphologically different stage embryo. That is called COFENAS. That's the strategy. If at all, if you want to do some jugaad for recurrent implantation failure, then you should do it, not the sequential transfer.
Yes. Okay, thank you. Thank you, sir.
Now 1, 2, 3, 4, 5, 6. 6 people are there. How many questions, or you want to conclude?
Yeah, no problem, sir. We will go ahead with whatever questions.
Okay. Then coming to Dr. Rekha Gupta.
Yes, good evening, sir. It was a beautiful lecture. And I was asking these companies, sir, which we are going to give the ERA, are they varying in their rates, like, or they are equal rates?
Madam, he said that in lecture, his way of doing, and he has already mentioned that you have to bargain hard, and they are coming down. So that already mentioned. I think I saw you left in between the lecture, in between for some
can
time.
we get contact numbers of 1 or 2 companies?
On Vadik, can you do that?
We will
Dr.
do
Chinmay?
that. Yes,
Yeah.
we will do.
Okay, madam. Okay, madam.
Another thing I was asking sir said that batch, when we are batching, we can't wait, but when we transfer, supposing we get the reports, then that will be in different days for different patients. Na? Like once we're getting 130 hours or 126 hours, so we can't get one day all the transfers.
Yeah, so the problem is you are doing stimulations in batch, you are not going to do ERA in batches as well. Obviously, you are going to pick and choose few patients from your cluster who you think probably are going to have primarily displaced window, which are the indications I mentioned. Now, for those patients, you can make an exception and do I would say, a customized, personalized embryo transfer rather than putting them in batches. That would be the only way out, wherein you may have a ERA in cluster, you may have a batch stimulation, but when it comes to the embryo transfer part, those few, how much percentage you are going to have? You are going to have around 15, 20%.
1 or 2, yes, sir.
Yeah.
Okay. So that will be done on different days, yes.
Yeah, but your pregnancy rates will improve significantly, no?
And sir, lastly, I was asking progesterone. You said give it only vaginal. So, but in our other IVF cycles, we give injection progesterone also on the day of, starting from the day of OPU. So, Rajesh sir, should we all switch over to vaginal progesterone on the day of OPU, to get better results?
See, if you want absolutely a predictable rise of progesterone in serum level, then the vaginal is the best. If you want predictable reach of progesterone in the endometrium, then vaginal progesterone is best. But if you want thoroughly maintain uniform level of progesterone in the blood, then injectable is better. If you want uterus to come down, then injectable is better. So everything has got its own merits and demerits. So here, because in original studies as well as whatever they have suggested vaginal preparation. Am I right, Dr. Chinmay?
Yes, sir, absolutely.
They have suggested intramuscular injection? No, no?
No, absolutely not. See,
For
the
that, what simple is?
problem is,
so
what you have to understand, madam, is with the help of vaginal progesterone and with the help of ERA, you can perhaps do away with those painful injections in some cases. That's what I'm trying to tell you.
Okay. Okay. So, like only during Rajesh sir, when we do ET, then we have to remove that progesterone tablet, no, thoroughly.
No, why you want to? You should be like the eye of the Arjun only. While after putting the cusco speculum, you just the portio vaginal cervix, portio vaginal cervix. Just clean thoroughly that part. Even on the side of vagina, if the capsule are lying with the half melted capsule, that is not going to harm you. So
Okay,
don't try to clean it. Let it be.
Okay. Thank you, sir. Thank you.
Yeah.
Okay.
Then comes Dr. Galaxy J7 Pro.
Hello.
Yes, please introduce yourself.
Hello, sir. I'm Dr. Sarika. I am from Alwar, Rajasthan. I am a beginner. I just wanted to ask a very simple question. How do you calculate the hours of the embryo? Is it from the time we do the ICSI?
Yes, from insemination. Yes.
Thank you. Thank you.
Dr. Vidya. Dr. Vidya? Dr. Vidya from Honaward.
Hello, sir.
Yes.
Hear me?
Yes, yes.
Hello. Can you hear me?
Yes, yes.
Dr. Chinmay, it was a nice, excellent lecture regarding this very confusing topic. I have two questions. You told biopsy site should be from the fundus. So it should be only from fundus, or you can take from lateral wall also?
Yeah. So I think, sir, one part I forgot to mention, how my personalized way. Please don't touch fundus. Just insert the catheter and just roll it 3 times. How the classical endometrial scratch is explained, no? You have to be so gentle in taking that endometrial biopsy that you don't end up damaging the endometrium for a subsequent cycle. So all you have to do is put in the cannula inside the uterus reach till mid cavity, stabilize your hand and just roll it 3 times. What you will see is beautiful, clear, white, transparent endometrium. It will be so transparent that you will be confused whether you have taken anything or not inside cannula. Only if you are traumatic, then you will start seeing your cannula full of blood. But a good secretory endometrium, if you just rotate the cannula beautifully, you will see all endometrium getting collected, and you don't, that too without any pain to the patient.
We have to rotate 3 times, 360 degrees.
Yes, just roll it 3 to 4 times. That's all.
The second question is, you told non-informative endometrium. So do we need to repeat the biopsy?
Yes. So the cases where there is a non-informative endometrium, first of all, those are very less. But even in those cases, they do not jump the gun and say that this particular endometrium does not exhibit any identifiable transcriptomic signature. What they mention is, please repeat the cycle, please resend the sample. Obviously, they are cautious enough to say that. And usually even these non-informative endometriums, if you wait for 3 months, send the biopsy again, sometimes you do get a different result. I've seen that.
But do they charge for additional biopsies?
No, they won't.
And sir, whether the down regulating the HPO axis for this, we usually down regulate for FET, but here we are doing without down regulation. So does it make any difference in the result after when you're doing FET after down regulation?
No, see, that's the whole point. No, whether down regulated or not, we are talking about endometrial receptivity based upon progesterone exposure to the endometrium, right? Now
Yes,
here, whether if you have a patient who is beautifully down regulated, nice endometrium, you have transferred embryos, and if she has conceived, no problem. But if you have that patient where everything was green, everything was good, and yet the cycle has failed, then perhaps there lies your problem of endometrium, and there you need to check her endometrial receptivity. And in those cases, then rather than down regulating, you have a simple HRT protocol which will give you pregnancy.
And sir, in our
Because
places,
GnRH analog has got adverse effect. Very recent papers are coming up. Agonist as well as antagonist both have some negative effects on the endometrium receptivity.
sir, in our place, we
Yes.
don't get report of progesterone immediately. It needs takes 24 hours. So then how to go ahead?
So that is why I said that please don't follow the company guideline of monitoring progesterone value of less than 1. You
Yes, sir.
stick yourself to 0.6 only. So even if it take 0.5 only, so there is no problem. You start sending the progesterone value on day 8 itself the moment you see good endometrium. And you should have that much clinical acumen where you see a good endometrium, your progesterone is 0.2, 0.3. I'm telling you, most of the cases you will see progesterone of 0.1, 0.15 like that. Hardly you will get any progesterone rise. But even if let us assume you have a progesterone of 0.6, even if you are going to get report after 2 days, how does it make any difference? You are going to make your assessment based upon what you see in the endometrium. Let us say that your endometrium on day 8 is fantastic. Then 9 out of 10 times your progesterone is going to be under control. Let us say if it happens that after 2 days your report comes more than 1. You tell the patient that this month endometrial biopsy is not possible. That's all.
Dr. Preeti.
Hello, sir.
Only one question. Huh?
Yes, sir. That was a wonderful lecture, sir. So my only question is, interpreting this ERA cycle, is it play with the number of hours for the embryo transfer, or does it have anything to do with increasing the dose of progesterone? Because we had a patient, she had a non-receptive endometrium, and I usually give injectable progesterone along with natural micronized progesterone. So when we spoke to the lab personnel, they asked us to increase the progesterone dose, and the injectable progesterone dose was double, and it gave a pregnancy.
No, what do you mean non-receptive endometrium? Because non-receptive endometrium either it is
that was not mentioned, sir. That after your lecture only, I was thinking about that. It was not mentioned if it's pre-receptive or post-receptive.
called as a non-receptive endometrium. If you are having a non-receptive endometrium, then your lab must provide you with whether it is pre-receptive or post-receptive. If it is pre-receptive or post-receptive, in such cases, increasing the dose is not going to change. Perhaps in your case, God was so kind that when you increase the dose so much that it basically jumped the window beyond. And probably you were dealing with something, I would say early receptive, where by pumping excess progesterone, you just got lucky. But I can assure you it will not happen every time.
Okay.
Dr. Indu Chauhan.
Good evening, sir.
Good evening.
Hello, sir. I'm audible.
Yes.
Good evening, sir. It was a wonderful lecture, sir. In between, my connection was very bad. So I just have one doubt. Like you told that you give intramuscular progesterone just to make the uterus quiescent 50 hours before. So that means that the single dose intramuscular progesterone you give, rest you give by vaginal route.
No, I said. He said, see, for ERA testing, he doesn't advocate injectable.
Yeah, not sir, no, sir. Yeah, I'm not talking about ERA. I'm just talking about the before embryo transfer. I think yesterday you told us. Yesterday.
Yeah, injectable. Yeah, I give one sort of intramuscular progesterone before 30 hours.
Single dose. Otherwise, all vaginal.
Yes.
Okay, so because we give this injectable, which is very painful for the patient. So this is the new thing which I have done.
Yeah.
And thank you very much. Thank you very much for teaching us so much. It was a wonderful.
Yeah. Thank Coradia sir for that.
Dr. Sarad, now three questions. Three person. Dr. Sarad, only one question. Dr. Sarad.
Hello.
One question only, sir.
Yes, sir. Per se, I don't have any question. I would like to thank you, sir, and thank you so much, Chinmay, sir. However, I am also doing ERA and it's more than 50 cases, but the protocol and everything is different.
Why don't you share how you do?
Okay, can I, sir?
In our verdict group, or we can have your talk maybe after 2 days. I think we have a very short topic. After that, you be ready. I will invite you to share your protocol.
Okay, sir. One thing only I
wanted briefly, if you can tell us how differently you do.
Okay, sir. Only one thing I would like to ask that if you are starting this without down regulating or in non-stimulated cycle, but in naturally patient will get follicles, no, sir.
If you start your estrogen on day 1, day 2, how will you get follicles?
If suppose
Chances
we
are
get them, we
6%,
have,
6 to 10%, not more than that.
okay, okay. If
If
that
that happens, then like I said, that happens, then it is safe to cancel that month.
Okay.
I would do that. Perhaps senior like Koradia sir can also rescue situation from that, but I would personally cancel because it becomes too much to handle. On one side you have LH follicle, on other side you have, so it becomes very difficult to manage.
Okay,
And
okay, sir.
importantly, that follicle you have got it by chance. Now you have got a follicle. Now you suddenly have a ERA test based upon natural cycle. Now next time, if you don't get that follicle, what are you going to do?
True. Okay, Doctor sir.
Yeah.
Galaxy S8. Galaxy S8. I have unmuted. Yes.
Yes. Hello. Sir, I am
Please.
audible?
Yes, you are audible. Please ask only one question.
Okay. Sir, what is your freezing and thawing protocol? Like you are freezing blastocysts at how many hours, and we have to thaw before how many hours for transfer?
It is entirely
For
different. Entirely different talk, madam. We are running very late.
No, for ERA.
For
Sir,
ERA. Okay. For ERA. Okay.
For ERA, because
Dr. Chinmay.
he is saying that 120 hours.
See, like
Dr. Chinmay.
do one thing, please try to understand that the freezing protocols are not dependent on ERA. The ERA is dependent on freezing protocol. What I'm trying to say here is, Koradia sir has already mentioned.
No, protocol is how many?
No, that's what I'm coming
you are
to.
freezing embryo.
If that's what I'm coming to you, you have got a good blastocyst at 118. Okay. As soon as it reaches the blastocyst, I would freeze the embryo. I would then not wait it to hatch. Getting it?
Okay.
The moment you see the blastocyst is happening well, and if it is you see it at 118, then you go and freeze it. Now, advantage in my case, I get to see in time lapse. Immediately we can act.
Okay. Hello.
Yeah.
Yes. That was over.
Hello.
Yeah.
Hello. First, we will talk.
Yes. Ask your question, please.
1 plus 60.
Yes, sir. I would like to ask one question, sir. That in ERA we are giving micronized progesterone 400 milligram BD 8 hours. You are saying, but routinely I give for this luteal phase support injectable progesterone and gel. Will it do?
See, madam, the thing is, when you are doing ERA test, okay, whatever progesterone support you are going to give from the time of exposure or addition of progesterone till the time of transfer, you cannot change that, and ideally you can safely keep it for vaginal. After doing embryo transfer, if you don't feel safe continuing with only vaginal, and even if you want to add extra masala to it, it is not going to change the implantation pattern. The point is, we are talking about the maximum window of implantation. Now, what you do after that window closes does not have any bearing as far as I understand, but Koradia sir can explain it further.
True. iPhone. Last question.
Yes.
iPhone.
Good evening, sir.
Good evening.
Sir, if the patient is not regularly menstruating, can we give withdrawal bleeding with progesterone and then start the stimulation, give
Absolutely.
for ERA?
Absolutely.
No problem. Absolutely, you can do that.
Okay, sir. That's my query, sir. Thank you so much, sir.
Yes.
Thank you. So that was the end, boss.
Yes, sir.
Maja aa gaya. Enjoy, Dr. Chinmay.
Yes, sir.
I never imagined you were presented so interestingly, and lot of comments and lot of people, they are really thanking you.
Yes, thank you.
Enjoyed thoroughly. It was exhaustive. 3.5 hours. 3 hours and 31 minutes. We have 35 minutes, I would say. We started 10 minutes before.
Yes,
So
sir. Yes.
3 hours and 40 minutes we have discussed. घर वाले मारेंगे यार. Okay. Chalo, nice to see you. Nice to be with you. Yeah. Thank you.
Take care. Yes, sir. Bye.
Yeah.
Bye.